Okay. I want to thank everybody for attending another Health Service Committee meeting by Zoom, and in accordance with Governor Newsom's executive order, which allows this committee and presenters to participate remotely via audio conferencing. I'm going to begin by asking the Secretary, Ann Shaw, to call the roll of the Health Service Committee. Ann?
Thank you. I'm going to just be calling the voting members of the committee to be sure we have a quorum. Blum, Goober.
Here.
Lansing.
Here.
Makarishian.
Here.
Napolitano.
Here.
I heard you, Hadi. Napolitano.
Here.
Newsom. Park. Perez. Oh, Lark. Park here. Okay. Perez. Sherman.
Here.
And Zettel.
Here.
Have a quorum.
Thank you. We're first going to hear from members of the public who have signed up to speak to us today. To our guests today, we want to welcome you and thank you for your interest in the University of California and to take the time to be here. The Regents always appreciate your observations and comments. We feel that it is important for us to hear from the public on issues concerning the University of California. As the notice on the Regents' websites indicate, because of health and safety considerations with regards to public meetings concurrently confronting all state agencies, public comment today will be by telephone. The Secretary will be calling individuals when it is their turn to speak. Please be patient as we do our best to hear from as many of you as possible, both in person and by telephone. So I'm going to turn it back to the Secretary, Ann Shaw.
Thank you. This morning we have 3 individuals who signed up to address the committee. So per policy, we will let them have up to 3 minutes to address the committee. I'll call all 3 names and then we will be dialing their phone numbers and connecting them by audio. So this morning we'll hear from Celine Dill, Claire Vandemark, and Christy Monsma.
Celine, please proceed with your comments.
Okay, hello. Can everyone hear me?
Yes, we can. Go
Hello?
ahead. Yes, go ahead, Celine.
Okay, thank you. Okay, here goes. Ladies and gentlemen of the board, I respectfully submit my comment to urge the Regents of the University of California to take action in support of emergency diploma privilege for 2020 law school graduates. Due to the COVID-19 pandemic, the California Supreme Court has ordered that the bar exam, originally scheduled for July, be moved to September and taken online. Recently, the court has issued a statement that the bar exam could potentially be moved further back to October. The court is deciding how to ensure administration of the bar exam without considering the impact this delay will have on test takers. Unlike other professional certification tests, the recommended time commitment to study for the California bar exam is 400 hours minimum. Currently unemployed graduates have difficulty splitting time between their job search and 400 hours of study. And most law graduates who have secured employment are scheduled to begin their jobs after they take the bar. Many law graduates simply cannot afford the months-long delay that has been imposed by the court. Diploma privilege would allow students to seek work as lawyers now, rather than extending their period of unemployment. With diploma privilege, law graduates, by merit of having earned their JD degrees, could practice law in the state of California immediately. Utah was the first state to embrace diploma privilege, allowing graduates of ABA-accredited law schools with at least an 86% first-time bar passage rate to practice law, subject to other specified conditions. On June 12th, the court in Washington announced that diploma privilege for its 2020 bar applicants, following a June 10th letter from the Seattle Law School Dean Annette E. Clark. I strongly recommend the board read this letter, as it addresses many important concerns I unfortunately do not have time to touch on in my brief comments. Deans from the California law schools had recently written a letter to their court as well, but the California deans asked primarily for certainty as to an exam date and only suggested provisional licenses as a possible alternative, a far cry from the clear support for diploma privilege that many law graduates had hoped for. The law school class of 2020 is not a very large group of constituents, and among so many other emergencies caused by the pandemic, our voice risks being drowned out. I ask the Board of Regents to take steps to give California a voice for diploma privilege and advocate for the competency of their law graduates from Berkeley, Davis, Irvine, and Los Angeles. Thank you. I yield my time.
Thank you.
Claire, please proceed with your comment.
Good morning. Hello, my name is Claire Vandemark, and I am a registered nurse, CN3, on 9 and 13 ICU at UCSF. I have worked on the unit for 11 years. We have acted as a COVID unit through the pandemic. During Nurses Week this year, we had a nurse taken out of our grid, making us out of ratio. This stresses the role of the charge nurse and leaves our unit short-staffed each day. This was a decision made to crunch the numbers for a budget and has nothing to do with patient acuity. A week ago, I submitted to Sheila Antrim petitions signed by our staff in objection to the grid change, as well as a letter pleading for the nurse back. She has not responded or made any changes. In each shift, we have to continue to make unsafe assignments in our ICU. UCSF is prioritizing money over the safety of patients and nurses. I was informed that I had 1 minute to speak, so I yield the rest of my time, and I appreciate you all hearing me on this.
Christy, please proceed with your comment.
Good morning, and thank you for giving me the opportunity to speak. My name is Christy Monsma, and I have worked as a registered nurse at UC Davis Medical Center since 2006. I am a proud union nurse and a member of CNA. In my time at UCD, I've worked in transplant services, the emergency department, and most recently, since 2013, perioperative services, specifically the PACU and the Children's Surgery Center. I've been offered positions at competing hospitals, but have always held true to UC Davis because I believe we have the best nurses in the region. Our department managers are currently proposing a mandatory call that is reportedly due to the backlog of cases related to COVID-19. I would like to point out that the same management has tried to implement mandatory call in 2015 as well as last year, 2019. If this was for COVID-19, a time frame would be established with a finite end date. The current proposal does not include an end date. COVID-19 is a convenient opportunity to force nurses to work mandatory call. Nurses have been ranked the most trusted profession for the past 18 years by Gallup's ethics survey. It's because we're caring by nature. We oftentimes care so much that we go above and beyond on a daily basis. Asking us to go even more over what we already do is bound to put a stressful burden on already exhausted nurses. Mandatory overtime has been shown to cause increased fatigue, burnout, and stress. These issues will directly lead to adverse patient care. I want you to think about if you or one of your loved ones was having surgery. Do you want an overtired nurse caring for you or your family member in the recovery room? A recovery room nurse is trained in critical care. There are 2-to-1 ratios in this department because of the risk the patient inherently has due to surgery and anesthesia. Do you want the nurse on his or her 14th, 15th, 16th hour taking care of you or your loved one? The nurse that hasn't had a day off to regroup and has been called in on a mandatory basis? I know I sure would not. The numbers we're hearing from management are 12 hours in a 4-week block. If you take our unit's 100 nurses times 12 hours a day, that's 1,200 nursing hours. Divide that by 30 days and you have 40 nursing hours per day. This shows that we are understaffed. With our current voluntary call system, nurses are called in the majority of the time for daily staffing needs. We need more full and part-time nurses, not mandatory call. I'd like to circle back to why I work here. We have the best nurses in the region. I know that if mandatory call is placed, many of these experienced, dedicated nurses will take their talents to competing healthcare systems. This will put our patients at unnecessary risk due to loss of experienced nurses. We want to work with the university to address the crisis that we're facing, but we will not compromise on nursing practice or patient care, which is what our management is attempting to do. Regents of the University of California, I urge you today to stop mandatory call in the PACU at UC Davis and continue to use the voluntary call system that is currently in use for the safety of our patients. Thank you. I yield my time.
Thank you. Regent Lansing, those are all of our speakers this morning.
Well, again, thank you to our speakers and thank you to everybody for being here today. Can I have a motion for the approval of the minutes of April 15, 2020?
So moved.
A second?
Second.
Anyone object?
Have
Then
to do
the,
roll call because it's.
oh,
teleconference.
sorry.
Sorry.
I apologize. Thank you, Ann. Please,
No
let's have a roll call.
Okay, to approve the minutes, Goober,
Approved.
Goober, yes. Lansing,
Yes?
Lansing, yes. Makarishian,
Yes.
Makarishian, yes. Napolitano,
Yes.
Napolitano, yes. Park,
Yes.
Park, yes. Sherman,
Yes.
Sherman, yes. And Zettel,
Aye.
Zettel, yes. Minutes approved.
Thank you. Before we begin our agenda today, I want to acknowledge Dr. Byington, her team, and our 5 UC Medical Center CEOs and their team. They have truly been heroes at the forefront during the last 4 months of this pandemic, and the word that is correctly used is heroes. I am so pleased also to see that some of our doctors have traveled to other parts of the nation that have been severely impacted by COVID. And some of them will be with us today for our speaker series later in the morning. And we also have on our agenda an update regarding the fiscal impact of COVID on our academic health centers. But despite all of this, the university carries on. We carry on in spite of COVID. And our agenda today reflects several important capital project actions and other health-related discussions. A reminder once again to participants that as we proceed this morning, please mute yourself unless you are speaking. And please use the hand raise feature on your iPad or computer if you have any questions. I'm now going to turn to Dr. Byington. And Dr. Byington, I'd like you to lead us through items 1 through 4. And then after 4, I'm going to ask our student observer, Noah Danish, to speak. And then we're going to turn it back to you. Okay, Dr. Byington, please proceed.
Thank you. Good morning, and thank you, Regent Lansing, all of our regents, President Napolitano, and guests. It is my privilege to address you on behalf of UC Health. Before I begin my review of COVID-19, I would like to recognize President Napolitano. I am so grateful that she could join us today, in which I believe this may be her last meeting with Health Services Committee as president. Throughout her tenure, she has elevated UC Health across all of our missions, education, research, and public service. As she retires from presidency, all of the medical centers are ranked in the top 10 in California. She has supported the creation of resources that help us to act as a system, including the creation of the University of California Health Data Warehouse, which pulls information from all of our medical centers and has been an indispensable resource for the management of the COVID-19 pandemic. She has supported the creation of the University of California BRAID, which links all of our clinical and translational centers together and allows us to be an engine for clinical trials for the state. She chaired the California Health Workforce Commission, creating recommendations that inform our training programs to better meet the needs of the state. And she established support for Dreamers and undocumented students, including all of those within the healthcare professions. I have greatly enjoyed working with President Napolitano in my short time at University of California. She has eased my transition and has been an exceptional leader during these unprecedented pandemic times. I have been able to count on her support for UC Health and for the UC Health Coordinating Committee. Thank you, President Napolitano, on behalf of UC Health for all that you have done.
Thank you, Carrie. That was really nice. Thank you.
Thank you. Thank you very much for joining us.
I just want to echo that. I was going to save that for the end, but all of us, President Napolitano, are so extraordinarily grateful for your leadership in all ways. But since we're in the Health Committee, we would not have a Health Committee without you, because that's when it started. And so for being the leader and making this happen, and also, I'm going to say Janet, because that's how I feel, your leadership in all issues. I just tell you, I miss you already. That's all I can say. But I'll now turn it back to you, Dr. Byington.
Thanks, Sherry.
Thank you so much. And Ann or Mike, if I could have the first slide, please. I think it'll come up here in a second. Ann, Michael?
Micah, are you there?
We're bringing it up in just a moment.
Okay, thank you. Okay, here we go. Thank you so much. Our last meeting of the Health Services Committee was April the 15th. And just as a reminder, at that time, there were 2 million cases of COVID-19 in the entire world. Today, there are over 2 million cases in the United States, and we have been aware of the novel coronavirus now for 6 months, and we've been in a recognized pandemic for 3 months. This slide shows where the United States is as of mid-June in comparison to the world. Next slide, please. And this is just a closer look at the United States itself. Again, with the most recent numbers, you can see that there is definitely a downward progression on the number of cases that we're seeing across the United States, and that is the good news. Next slide, please. However, there's significant variation across the nation. We are a large country by geography, and the downward trajectory of cases across the United States is primarily driven by the decrease in cases in the Northeast, particularly New York and New Jersey. And when you look at the slides, that the curves that you see here, the epidemiologic curves you see here, we are seeing increases in cases now across the South and across the Western United States. Next slide, please. And just as a reminder, California, we've done an excellent job, but we are not finished yet. This map shows hotspots across the United States as of June 12th. States are marked in red if they have more than 400 new cases each day. And you can see California leading the way with 2,700 cases on June 12th, the day I took this picture. We are still routinely reporting over 2,500 cases a day in California, and we do remain a state of interest across the US. Next slide. And so this is where we are today in the COVID-19 pandemic. We have not had the usual bell-shaped curve that would be expected across the United States. We are at something that I would call a plateau, a somewhat unexpected place to be. We have been able to flatten the curve, but not eliminate transmission. And because we've had different responses across the US and we travel state to state, we see different outbreaks across the state that has led to this flattening. We had hoped maybe early in the pandemic that we would see a sharp decline by the summer months and perhaps have some respite before we go into the fall, but I don't believe that that is going to occur. I think we are going to be on this plateau for some time. The majority of our California population, likely 96 to 98%, remains susceptible to COVID-19. So as we begin to loosen restrictions and interact more in person, we will see additional cases and outbreaks. Being on the plateau, we need to reframe our approach. The pandemic is moving from an acute to a chronic condition that we will need to actively manage and be always prepared for exacerbations or surges in case counts. There is some good news, however, regarding the management this week, with the announcement that dexamethasone, an inexpensive steroid, appears to be an effective treatment, reported to decrease mortality by 30% for patients who require a ventilator and by 20% for those who require oxygen. We wait for the peer-reviewed publication of these data for final judgment. We also now have a number of studies indicating consistent use of masks can lower transmission. And I expect for us to be on this plateau and in the type of management preparedness mode for at least the next 2 years. And I look forward to additional interventions that will help us lessen the burden of disease until we have a vaccine. As I was preparing for this meeting, I decided to look back on my first remarks to the Health Services Committee as EVP for UC Health, which honestly seems like a lifetime ago, but actually was December the 10th of 2019. As it was my first meeting, I described my experiences and how they influenced my practice of medicine and vision for UC Health. I described at that meeting both pandemics and health disparities. and noted that these experiences further influenced my views that the health of one person influences the health of all. Looking back on those remarks, they give credence to the adage, begin as you mean to go on, and go on as you began. My team knows my commitment to consistency, and I intend to go on as I began, dealing with pandemics and health disparities. Although it would have been hard to predict then, it was clear by January 2020 that expertise related to infectious diseases and pandemics would be a primary requirement for maintaining operations across UC Health. It is clear to me now that the UC response and recovery from the pandemic will be my primary focus for the foreseeable future, and this work provides a once-in-a-lifetime opportunity to remake our health system in ways that support our mission to work to deliver health equity and to serve all Californians. The first few months of the pandemic have been a time of unprecedented change and intense work across UC Health. For me, it has been a time to learn to lead a new organization and to form relationships. There were the unending requirements of the early pandemic, including learning about a new virus. This task included learning the basic science of the virus, its proteins, its binding sites, the epidemiology of infection, and public health interventions that might limit spread. It meant understanding potential treatments through clinical trials and identifying health disparities that should inform public policy. The work also included preparing the hospitals for surge, learning to care for patients while protecting healthcare workers from infection, using technology to support care and to work from a distance, addressing the economic fallout of preparations and changes to the healthcare operations, and more recently, understanding the chronic nature of the pandemic and working to find ways to safely return essential services to our hospitals and to resume more normal functions across the campuses. All of these are potentially daunting activities, and they were made easier by being part of the University of California system because of the depth and breadth of expertise across our campuses and our national labs. And as it turns out, making difficult decisions under time pressure and with many unknowns is a great way to get to know people and to get to know an organization. I am grateful for the opportunity to work with so many committed and talented individuals, including the president and her staff, the chancellors, the vice chancellors of health, the CEOs of all our hospitals, the deans of our health professional schools, the staff of the UC Health Division, and faculty and staff too numerous to name who have risen at every turn to meet requests for subject matter expertise and support for the UC Health Coordinating Committee for COVID-19. Pandemics are an interesting time in human history. People may refer to a pandemic as an apocalypse. The modern interpretation of the word apocalypse implies destruction and the end of something that we cannot imagine ending, like the world. I don't share that vision. I believe the world, the United States, California, and UC Health will survive and thrive after the pandemic. I do agree, however, with the apocalyptic language in one respect, and that is the origin of the word. The meaning of the word apocalypse comes from Greek and means to reveal or to uncover. Pandemics are great revealers and uncover the strengths and weaknesses in society, organizations, and people. The emergence of SARS-CoV-2 has been a revelation in the US and across the world. The deep connections across geography were revealed as we watched the SARS-CoV-2 virus spread to almost all countries and territories on Earth in 90 days. We have seen revealed the lack of preparedness in our country and in most countries for pandemics. Public health, clinical trials, diagnostic testing, supply chains, all have new resonance for people. We have seen the fragmented infrastructure in the US for both healthcare coverage through insurance and healthcare delivery. We do not have an equitable healthcare system in this country, but we long for one. And the crushing health disparities endured for generations by marginalized populations in the United States have been starkly revealed by COVID-19. Next slide, please. This is a slide that shows the COVID-19 deaths per 100,000 people by racial group. The dark blue line is the white population in the United States, and all other racial groups are compared to the white population in the US. The white population has a mortality rate that is less than its rate for representation in the full population. And all other groups have rates that are higher. For Black Americans, the rate is twice as high as their representation, their proportional representation in the population. And for other groups, the disparities are also stark. To give perspective, if Black Americans or other racial groups had died at the same rate as white Americans, at least 14,400 Black Americans, 1,200 Latino Americans, and more than 100 Native Americans would still be alive today. Next slide, please. These disparities in healthcare do not occur just for COVID-19. They have been here for centuries. And this shows a graph of the health status for groups, minority groups in the United States after the implementation of the Affordable Care Act. So these data are recent and come to us from the Kaiser Family Foundation. Individuals in these bar graphs are compared to whites. Their outcomes are compared to whites for many important health outcomes. And red means that your outcome was worse than white Americans. And you can see for Blacks, Hispanics, American Indians in particular, their health outcomes for the majority of measures are significantly worse than white Americans. And for Asians and Native Hawaiians, there are also disparities. These disparities are not accidents of birth, nor are the individuals who suffer these disparities to blame. Health disparities are another tragic result of the systemic racism that exists in our country and is more easily visible today because of the pandemic. It is much clearer today during a pandemic than it might have been in December when I said that the health of each person influences the health of us all. The public health crisis of COVID-19 has helped to reveal the public health crisis that has been present in our country for centuries. And that is systemic racism. These two health crises are now intertwined as people across the University of California and the world demand justice through civil protest and risk the spread of COVID-19 in the process. Next slide, please. These are scenes from across our campuses as people recognized the Black Lives Matter movement, supported our patients and those from underrepresented groups, and recognized the health disparities that exist today. And these are our students, faculty, and staff from across our campuses participating in days of remembrance that occurred last week. We have an opportunity today to hear about work by our clinical teams who were serving in New York City and in the Navajo Nation, and we will hear plans for the medical education at UC Merced. These are tangible examples of the work of UC Health to build a more inclusive health system and to stand in solidarity with communities and patients seeking health equity. Periods of pandemic may also reveal what is best or necessary, and they beg for reflection and change. What will be left behind and what can be remade in the future? The return to the status quo should not be our goal. As we discuss later today, our outlook for economic recovery and opportunities for new ways of working together. These times are a clarion call for a mindset of remaking, not just rebuilding. At UC Health, we will push through layers of individual and institutional discomfort so that instead of working to return to normal, we will be forging a new normal, one that is more accessible to all. And in doing so, the University of California Health has the opportunity to be the health system for all of California. In December, UC Health held a retreat with our leadership. One of the outcomes was that we documented for the first time system-wide goals, which include our aspirations to improve the health of all people living in California now and in the future, promote health equity through the elimination of health disparities, and reduce barriers to access to our clinical education and research programs by creating more inclusive opportunities for employees, students, and trainees. I would like for these goals to be the cornerstone that we take into the future as we recover from COVID-19 and remake UC Health. All three of these goals speak to our aspirations of inclusion, health for all, health equity, and opportunities for access to clinical care, education, and research. I also want to take with us what we have learned from COVID-19 and our response, including lessons in collaboration, communication, preparedness, resilience, and service. Next slide, please. This slide shows one of those lessons learned and represents the work of UC San Diego Health and our telehealth and traveling ECMO programs, connecting UC Health providers with hospitals across California who need intense services and are not able to provide them in their communities. And so I hope to carry this spirit of service and also this spirit of sharing the technologies and the assets that we have in UC Health across our state. There will be many opportunities to use these strengths to become an even stronger organization. To that end, I have called a leadership retreat for July 17th of 2020. We will focus on our recovery from COVID-19 and the remaking of our enterprise. We are resilient, and we will look for new opportunities to serve and promote health equity, to lower costs of care, to reduce barriers to access for our patients, students, and trainees, and to improve the health of all Californians. We will discuss opportunities, including a platform for inclusive excellence for leadership across our enterprise. We will discuss strategies for collaboration and communication across the system and with the state, and build on relationships that were created or strengthened during the pandemic, particularly across our individual campuses and with the governor's office and the California Department of Health. We will look at ways to optimize telehealth for outpatient and specialty care, and including inpatient care through affiliation agreements. We will look at how we use our data that informs us to make better decisions across our own system, and to use data to track outcomes, including health disparities and the impact of our system on relieving health disparities. And finally, we will look at health benefits. We have an opportunity to leverage our health benefits program for the good of the institution, our employees, students, trainees, and the state. So now, last slide, please. It's a time for a couple of thank yous. We will be saying goodbye to two people on our Health Services Committee. First, Dr. Stephen Hetz from UC San Francisco. Dr. Hetz is a professor of neurology at UC San Francisco, and he was appointed as a member of the Health Services Committee in July of 2018. For nearly 2 years, Steve has brought to the committee the perspective of the academic senate and voiced the importance of bringing the provider's voice to the committee. We are so grateful for his contributions to the work of our UC Physician Wellness Collaborative, and we will miss Steve as he transitions to other roles. Dr. Hetz will be succeeded by Dr. Andrew Beinman, who will start on July 1st. Steve, I hope that we can continue to call on you as we move forward with all our work together and rely on your expertise with telestroke care, and that you will still be a contributor or visitor to our committee. Thank you, Steve.
Thank you, Carrie, and thanks everyone. It's been a real pleasure and honor, and always happy to help you and everybody in the university.
Thank you. And then I'd also like to thank Mr. Steve Lipstein. Steve was the former president and CEO of BJC Healthcare in St. Louis. He was first appointed as the external advisor to the Health Services Committee in March of 2016. For over 4 years, Steve has provided direct and honest insight into the healthcare landscape and has aided the committee in vital ways. Particularly in January of 2018, when President Napolitano launched a comprehensive restructuring effort for the University of California's Office of the President. As part of this restructuring, the President appointed an advisory committee to determine a set of recommendations for UC Health Division. The committee was chaired by Steve and was asked to explore all structural, funding, and associated governance options that would enhance UC's agility and flexibility to reach long-term strategic objectives, and at the same time ensuring transparency, accountability, integration with the UC system as a whole. The advisory committee's final report was presented in October of 2018 to the Health Services Committee, and we are so grateful for Steve's insight. We will greatly miss his unique ability to hone in on issues and in the midst of every committee item. So thank you very much, Steve.
Carrie, thank you. It's been a real honor and privilege to serve. I wish the best of all things possible to you, to UC Health, to the University of California in its totality. And I send my very best to all of my friends and colleagues in California. Thank you.
Thank you so much. Regent Lansing, that concludes my remarks, and I'm happy to answer any questions if there are questions, and if not, we'll go on to the next item.
I don't see any hands raised. And I'm just going to take the liberty of the chair. I was going to do this before the end of open session, but you were thanking Steve Hetz, and so I want to extend my enormous thank you to you, Steve. You've been such a wonderful member of the Health Service Committee, and I know that we're going to stay in touch, and I know that you're going to be involved with us forever, even just as a consultant. I also have to now extend an extraordinary thank you to Steve Lipstein. Steve, you've been with us since the beginning. Your calm voice, your rational manner, your breadth of extraordinary knowledge have helped us navigate through so many different issues. I twisted your arm and begged you to stay an extra year because I felt that we needed your experience. I never thought we would be facing a pandemic. I never thought we'd be doing it remotely. But I have to say, it's hard for me to imagine this committee without you. So my deepest gratitude to you and thank you. Okay, I don't see any questions. So I think I will just turn it back to you, Carrie, Dr. Byington.
Thank you. So the next item is item H2. It's consideration of a hospital bed tower replacement by UC Davis Health and the Davis campus. UC Davis Health is proposing to construct a hospital bed replacement tower adjacent to the existing main hospital to address seismically deficient inpatient facilities and address obsolescence of existing facilities in order to address community needs for high acuity inpatient care and to respond to the growing population in the Sacramento region. Senate Bill 1953 requires seismic compliance with code, mandating the north-south wing to be removed from service by July of 2022 and the east wing by 2030. We will be joined now with Dr. David Lebarski, Vice Chancellor for UC Davis Health System, and Brad Simmons, Interim CEO of UC Davis Health System Medical Center, and Tim Maurice, Chief Financial Medical Officer, to go through the presentation. Gentlemen.
Thank you, Carrie, and thank you to the Health Services Committee for listening to us. Our requested action today is to approve the proposed presentation of the project and subsequent requests that will go to the Finance and Capital Strategies Committee for approval of P funding, approval of budget and design pursuant to the California Environmental Quality Act. As Dr. Byington noted, we have no choice but to put up a new tower, given that we have seismically deficient buildings and aging patient bed towers. The first one to come down was actually begun construction in 1951, believe it or not. And in order to sustain our current inpatient operations and to address our high acuity patients, we obviously will need to do this. We have done extensive modeling, demographic projections, population analyses, changes in expected utilization of hospital beds with both robust internal and aggressive outpatient external consulting input in order to make sure that what we're proposing will easily be fully supported. And then last but and certainly perhaps most important is the impact on our patients. Currently, with our aging facilities and the way that we're currently constructed, almost all of our beds outside of intensive care units are still double occupancy. That is not standard across most academic medical centers in the United States. And while this proposed project will get us part of the way there, it won't even get us all of the way there to eliminate all of our double beds, which is our actual eventual goal. Next slide, please. So we currently have 625 licensed beds. We are one of the 100 largest hospitals actually in the United States currently. And we have to demolish 157 beds in the course of this project. And we're proposing to build a tower that will have give or take 200 beds, and that there is the potential for additional bed tower at an adjacent site as well, if it turns out that we are able to either afford it or need to do it in order to address increasing volumes. And I don't know if anybody wants to go through the where it's all located, but you can see that the green square with the arrow is where the new proposed bed tower will be, and the bed towers that are being knocked down are to the left of that picture, north, south, and east towers, respectively. Next slide, please. The new rooms that we'll be constructing, of course, are patient-centered and will provide safe and secure and positive healing experiences for patients and families that we cannot fully provide at this time in our aged facilities. This is a very fiscally responsible plan, and we are very confident that we have both the available hospital reserves and financial wherewithal for future earning potential to support any borrowing that will accompany this building. We have a degree of resiliency in the fact that as we plan this, we have the ability to move our design forward with changing paradigms of care. And we'll probably have flexible, adaptable rooms that could be both inpatient med-surg or ICU beds as the needs require it. We imagine that most academic medical centers will migrate to having a lot of what's now currently inpatients housed in the hospital move out to domicile nearby facilities with hospital at home technologies. And that's one of the reasons we're not overbuilding at this time. Clearly, we'll have tremendously increased staff satisfaction. It's not easy to respect HIPAA and to provide the privacy and concern that our staff have for patients when there are double rooms. And obviously a facility built in 1951 is missing some niceties, as you might imagine. And last but not least, the new hospital will be designed to increase operational efficiency and utilize the latest technology in order to drive both improved patient care and improved throughput through the organization. Next slide, please. This is the proposed stacking diagram. It kind of mirrors that kind of picture where all the buildings were. The two towers on the left must be taken down, one by north-south by 2022. The one east has to come down by 2030, although there is talk that I just heard that someone's proposing the legislature moving that to 2035, but we have to demo that anyway. It's not sustainable or supportable. It requires tremendous tremendous infrastructure renovation costs. And then there's the University Tower, which if, again, either needs to be renovated, it also takes a lot of expense. It's almost 40 years old now. And really, again, as part of the staged plan, will eventually need to come down. Even though it's seismically safe, it is not an efficient building in which to provide modern care. And then all the way to the right, you see the replacement hospital tower, RHT. Again, it will focus on high acuity, high intensity services that you might expect the sole academic medical center for almost half the counties in California would need to be. As many of you know, we provide level 1 trauma services to 33 of the 58 California counties, and we serve as a referral destination for many of those partner hospitals, and we imagine we'll continue to do so. Last slide, please. So we have a phased strategy, which is, as we've said, we match the bed needs in a digital model that we have done simulation modeling on with GE as consulting firm around hospital building. We absolutely have the requisite funding to do phase 1. If we can grow and increase our cash flows, et cetera, we might be able to put up phase 2, but right now we are not planning to do that. But we do believe that the campus needs that. Unless someone knows a philanthropist out there who's really wants to invest a lot of money in Sacramento. It fits within the long-range development plan in terms of size, height, and setbacks for our community. And it will, by doing it in a phased manner, reduces the initial impact of both central plant and infrastructure. So we don't have to spend extensively on anything but the building that we're putting up. So again, a very conservative, very wise, very forward-looking, future-oriented plan that will not leave us with excess hospital beds when all is said and done. All right, that concludes my presentation, and I'm happy to take any questions or provide any further information that anybody might want.
We have several questions. I'm going to take them in the order that they came up. So Regent Markarishian first.
Okay, thank you, Sherry. No, first of all, I want to say that this is an excellent project to start at this point for me because of the financing situation. We just the finance and capital strategy just approved raising $1.5 billion, but I think that amount could be easily increased. Universities like Stanford and MIT and all the other universities are taking advantage of the low rates right now that's available for financing. So I would encourage the UC Davis to be talking to Nathan and perhaps include the first 2 phases design and all that stuff into that portion of the financing. That's one comment. Second comment is that have you all of these designs, are they I know this is going to come to the finance and capital strategies committee, and we can ask all these questions, but are these drawings that you're showing, are those pre-COVID or are they post-COVID designs? Because I see the height of the building and all that stuff. Have you taken into account all the needs now with the elevator sizing, positive, negative, forced air pressure and that kind of stuff?
Right. Regent Markarishian, thank you. Those are great questions. So yes, we do agree that we should be seeking as early financing and as aggressive as we can, given the cheap availability of money. Our CFO, Tim Maurice, is here, could speak more to it, but we are in a good position to do so. And if we could accelerate the building, we certainly would, given that will reduce the total cost, not only of the building, but of the money that we borrowed to do so. So we will be exploring that for sure. In terms of it being a pre versus a post-COVID design, it is a pre-COVID design. And we do need to consider things such as larger elevators or faster elevators in order to not cause crowding, because this will not be the only infectious disease that we'll see in the lifetime of this building. It will be occupied, we hope, in 2027. It should last until 2060. And so, we need to be thinking this way. And I don't think that, of course, we were thinking that way, to be quite honest with you, prior to COVID arriving. We have thought about it from a negative pressure standpoint, from an infection control standpoint, but the crowding standpoint, quite honestly, I don't think that we took that fully into consideration. May I ask my CFO to comment?
Well, again, we have initiated programmatic design, but we have not done the design phase. And that's what this funding is for the design phase that will take into account COVID and other infectious diseases in the design of the building.
Right. So we will incorporate it, and the rough initial drawings don't show that, but we have every plan to do so in this specific phase.
Okay, so by the time you come to finance, then you have those to explain to us as to, because you don't want to start the design and then 6 months from now change it based on the new codes that are coming out. That's one thing. And then since your CFO is here, in the item you state that you have 3 times debt service coverage and 149 days of cash in hand. Is that again pre-COVID or based on projections going forward?
That's based on projections moving forward as well.
Right. Yeah. This.
So going forward,
we remain in very solid financial shape at this time, and I'll just point out that our organization is 100% back to pre-COVID levels, and the apparent losses related to COVID have been ameliorated due to the fact that we had an exceptional year running into COVID at much increased volumes compared to initially budgeted. So we feel very confident that unless we have a really terrible fall, and again, no one can predict that, but at least at this moment in time, we are very confident that we have the resources currently and in the projected future to handle this.
Yes, the CARES
so then
was covered our losses today.
Right. I don't know if you heard our CFO, but we're very fortunate in that the immense planning done by Dean Brashear, who's on here with us, and Brad Simmons, our hospital head, really just tremendous work by them and our CMO to keep us fully functional. And the CARES Act monies that our CFO applied for and received did almost fully cover all of our losses through the COVID episode.
Great. So then I suggest that you talk to Nathan Nan or Paul Jennings to make sure that they know of your needs when they go to the market for that $1.5 billion. Maybe they can raise that to $2 billion. I've been trying to push them to raise it to $2 or $3 billion with these low interest rates at this point in time. Yeah. But they were telling me that they're coming to each one of the campuses okay, and asking them what they need. So this is one of those items.
I think that it's a great idea, and we will certainly pursue that.
Thank you, Sherry.
Sherry, I think you're still on mute.
I think we lost Sherry. So.
Regent Lansing, you're still on mute.
So while she's finding her microphone, my hand was raised.
Just happened. I couldn't get off of mute. Sorry, I don't know why, because I was pressing the button frantically. So Regent Settle, followed by Regent Park.
Thank you very much, Chair Lansing. First of all, I want to congratulate you on your economic recovery from the COVID-19 escalated costs and reaching your pre-COVID-19 occupancy rate. I think this is an excellent plan and certainly will increase staff morale, engagement, patient safety and satisfaction. But I do have a little question for you. What are you going to do with the north-south tower site as you demolish it and the east tower site? What's going to be?
So that's a great question. And I apologize, our facilities director is out sick today, or he would give a much more meaningful answer. I do have his assistant here, though, second in command. Do you want to talk about the site plan?
I could
discuss that if that, I'm not sure if they can hear well enough.
Yeah,
We
just-
need to reiterate. The north-south wing and the east wing, as they come down, will be future redevelopment sites, but in the shorter term, specifically on that far west end of the hospital, that's going to be developed as an open space, and it has been conceived of at this point, not planned, but conceived of as green space and respite space for hospital staff, and sort of to raise that satisfaction factor.
Right, and and if I may, there are also plans we've been discussing. We don't have the type of healing garden that many advanced medical centers have in place now for people really to find peace within a very complex and sometimes noisy and concrete environment. And we hope to use that space to improve our patient experience and our family and visitors experience as well.
Thank you.
Is that it, Regent Settle?
That's it. Thank you.
Regent Park, followed by Regent Sherman.
Okay, thank you, Chair Lansing. I guess I'm a little bit confused about the sequencing. So there are 157 beds that are in the towers that are going to be demolished. So is there going to be a loss of beds for a period of time?
There will be a short-term potential loss of beds from the east, the north-south tower, which is 29 beds. Part of that was with the, the advent of finding beds elsewhere to augment that. We would expect that the rehab hospital would be built by then. Those beds are critical to us maintaining our current levels of service, because we would then utilize the beds in the main hospital that are currently dedicated to rehab patients to offset the loss of the 29 beds that must come down in 2022. And that's why the timing and the progress is so critical for building the rehab hospital, because that is our short-term solution due to the seismic issues.
Okay, so it really is only 29 beds that you're trying to time, correctly in order not to experience a loss. But the 128 beds you would have built before anything else comes down.
Correct. We will have all the new hospital beds in place and occupied, and then we will phase out the 128 beds as we can, and then demolish that building by 2030. So there'll be a little overlap, and that will anytime you open up a new building, it's always good to have a little backup.
Okay, great. And then just out of curiosity, you've said you've returned to pre-COVID levels in terms of your occupancy. System-wide, I believe that number is 75%, right? So maybe some of the centers are doing far worse than 75, as you're now back to 100%. What do you attribute that to in terms of your region having sort of bounced back in its entirety versus other regions that are not? Can you shed some light?
Yeah, well, it's not the region per se. Those of you who didn't see, Sutter declared operating loss of $404 million through April. Dignity has similarly sized losses. I think it really is the people at UC Davis. They are just working amazingly hard. We were lucky. We recognized that we had truly flattened the curve or crushed the curve here in Sacramento. And we began planning to reopen back in April. As we were seeing that the peak was very low, we knew that we would be able to reopen if we made our staff and our faculty understand. Sorry, if our staff and our faculty knew, number one, that their safety came first, right after patient safety, and that then we could make our patients feel safe, and we gained their trust, both our people and our patients. And they came back relatively quickly, and we engaged literally hundreds of people in a highly organized, cascading way to reopen every single corner of our organization and address all of the concerns that staff, faculty and patients might have about returning for their care. And following Jonice's lead, quite honestly, we installed a Qualtrics survey that UCLA first developed and a joint marketing plan with all 3 other major health systems in Sacramento that is still playing to assure people that the right thing to do was to return for their essential care. So that's kind of how we ended up where we are. We're very fortunate, and part of it is because unlike San Francisco, which has the issues around San Francisco itself limiting patient movement and the much larger burden that the Southern California centers have in terms of COVID and continuing to stand ready on that, I'd have to say we're sort of lucky.
Thank you.
For the last comments, then it's Regent Sherman, and then we'll move on to the next item, Dr. Byington.
Thanks, Sherry. David, so give me an idea, under the LRDP, what is your total capacity that you have available to build out in the future?
That is a great question. It's not one I have at my fingertips, and I don't, Jill, do you happen to know off the top of your head?
The LRDP doesn't mention bed count. It talks about the build out area and also height restrictions and setbacks, but the bed count was achieved through doing the GE Healthcare digital twin
Right.
study.
Yeah. So we don't really have, so it's not tied to a bed count as it is to building size and building height and setbacks from the community. However, and then we worked our way back into what was the maximum number of beds that we might be able to put in this proposed tower at that proposed site. And again, our goal would be eventually, we hope, if we could build 400 new beds, which again, depending on borrowing costs and everything else, and go to a total single bed approach, we would then turn around and renovate the Davis Tower back to single room, and then we'd have the same capacity with all single rooms. And that is my fervent hope. But again, we are really aggressively pursuing hospital at home, the idea of potentially building a hotel with a bridge and a tower to actually domicile mostly recovered patients in non-hospital environments using high-def cameras and Bluetooth technologies. So we're keeping ourselves flexible so that we can not spend $5 million a bed where we don't have to.
Yeah, I guess where I'm coming out on this, you're adding basically 35 beds in this phase, right?
Yes.
Why not go bigger? Given there may be an incredible opportunity, given the low financing costs, what I suspect will be one of the best environments, construction cost wise, coming up. Who knows, there may be infrastructure money available coming down the pike because out of Washington.
From your mouth to everybody else's ears, right?
Okay.
I am 110% behind that. Nothing would give me greater pleasure than to double the size of this building, get our phase 2 financed and roll right into it. We definitely could use it. And it would definitely place us in the position in the region that we seek to occupy. I mean, through the incredible, great quality care our physicians and caregivers deliver, we really have become a regional asset. We had 12,000 transfer requests last year. We can only accommodate 6,000. And so we definitely could build more, but we have to have the cash flows to do that. And we're trying to be conservative, taking into account that we believe the hospital at home technology will really drive a reduction in hospital bed utilization over the next 20 years. And we're looking at this from a really forward-looking view. But if we could build the second tower, we could definitely fill it, and we would love to do that.
Yeah, I just imagine, when you do your planning, we typically have planning rates in the 5 to 6% cost of capital, and it's going to be much, much lower. It made the economics when you come to finance a capital maybe much better. Also, just a kind of a technical question, when you talk about operational efficiencies and all of that, what are you using, or what are your architects using kind of as a amount of square footage per patient bed? And how does that relate to maybe what San Diego is going to be building, or San Francisco in their towers? And what do we, as a system, are we having a new template of sorts?
No, we're very proud to be allied with our sister institutions. We're stealing right and left. This would be very, very similar. They've done tremendous groundwork that we have no problem copying. I'm going to let our facilities expert talk more to that.
Yeah, I don't think there's much more to add to that other than just we're using sort of an industry standard approach, and we're about to spend the rest of this calendar year going through a program validation that right sizes both the care spaces as well as service spaces and support spaces, very much in line with what the other UC academic medical centers are doing.
Thank you.
Okay, that is the last of our questions. So Dr. Byington, can we please move to the next item?
You want to vote on this, Sherry?
Oh my goodness, thank you.
I think we have to vote.
What would I do without Anne? Yes, can I thank you. And it's actually right in front of my eyes to do that, so it shows you. We need a roll call vote, so can I have someone move this, please?
I move approval.
And a second?
Second.
Okay, now we need a roll call vote. Anne?
Okay, roll call. Goober?
Yay.
Did Goober say abstain?
Yes,
Yes.
yes, yes. What did you say, Peter?
Yes, yay.
Yes.
Oh, yay. I thought you said abstain. Goober, yes. Okay. Lansing?
Yes.
Makarishian?
Yes.
Napolitano?
Yes.
Park?
Yes.
Sherman?
Yes.
And Zettel?
Aye.
Motion approved.
Thank you, Anne, for being so diligent. Now we're going to go to Dr. Byington, and I know Dr. Byington wanted to do item H4 before H3 because she felt it would provide some context. So Dr. Byington, I turn it back to you.
Thank you very much. The next two items are education-related items, and they are related one to the other. And it would be, I think, more informative to have item H4, which discusses California's medical education landscape presented prior to the proposed request for approval of the Health and Behavioral Sciences building on the Merced campus. So California faces a growing shortage and persistent maldistribution of physicians. And expanding the supply of physicians is likely best to be achieved by expanding medical school enrollment and pursuing growth in graduate medical education. So we will now hear from Vice President of Health Sciences, Catherine Nation, who will talk about California's medical education landscape, and she will be followed by Greg Camfield, Executive Vice Chancellor and Provost, and Dr. Thelma Hurd, Director of the UC Merced Medical Education Program, as they talk about their proposal for a new building on the Merced campus. So Dr. Nation.
Great. Can everyone hear me?
Yes.
Okay, good. Thank you, Regent Lansing, members of the Health Services Committee, President Napolitano, and colleagues. As Dr. Byington mentioned, I'm going to attempt to talk a little bit about the landscape, including a recap of where this state has been, where we are currently, and where we hope we will soon be headed with some new sustainable investments that are part of the current state budget. Before really moving into the details, I'd like to talk for a minute about some of our demographic system, our demographic context in terms of this state. I think everyone here knows that California is among the largest, the most populous, and the most diverse states in the nation. Our population will soon total 40 million people. It is culturally, racially, ethnically, linguistically diverse. Statewide, we have had very long challenges in meeting the needs of our medically underserved communities, with most of our counties carrying state and federal designations as shortage areas. And I think we see now, as Dr. Byington mentioned in her opening remarks, more clearly than ever, the tremendous disparities in healthcare access and outcomes that occur as a result of these shortages, and that have been truly painfully revealed in the face of the current pandemic and demands for improved racial and social justice. So about our doctors, our physician workforce in the state of California is also aging. We typically trade places among all states, with the oldest practicing doctors, I believe, with Hawaii and New Mexico. Nearly a third of our practicing physicians are now age 60 or older. Fewer than 10% of our active physicians identify as Latinx or African American, by contrast to more than 40% of our population. And then by the year 2030, this state is expected to have an estimated shortage of 41 primary care physicians, and to have only 2/3 or less of the psychiatrists that we estimate will be needed. And I'll say here that this finding was one among many that were cited in the final report of the California Future Health Workforce Commission, co-chaired by President Napolitano and CEO and president of formerly Dignity Health, Mr. Lloyd Dean, now at Common Spirit. Next slide, please. So this state, when we compare ourselves to others and national averages, has a relatively small medical education system. When we compare ourselves to a population of 40 million people and our fairly vast geography, on a per capita basis, according to the AAMC, California has a statewide medical student enrollment that is the 4th lowest in the nation, at 19.8 students per 100,000. And this is by contrast to a median of 32.7. This statistic is for all US states that have medical schools, and there are 4 in this country that do not. These are our WWAMI states: Wyoming, Alaska, Montana, and Idaho. So this provides, again, a point of reference for this state by comparison to others operating medical schools. We have roughly, in the 1920 current academic year, 7,800 medical students enrolled in California's now 13 medical schools. And I would highlight there the word now in light of changes in the past decade and those that are near term ahead. Next slide, please. Okay. Here you see the California medical schools that have students enrolled in the year 1920. On the left, you see our very own University of California schools of medicine at Davis, Irvine, UCLA, UC Riverside, UC San Diego, and UCSF. These are Doctor of Medicine degree granting or MD granting medical schools. They're also referred to as allopathic medical schools. To the right, you see California's private MD granting medical schools. The 3 at the top are long-standing Loma Linda University, University of Southern California, and Stanford. Following those 3 schools are North State University, right up near UC Davis, that opened in the year 2015 as the nation's very first for-profit MD granting school of medicine. This is a relatively new phenomena in medical education. And then we have California University of Science and Medicine in Southern California that opened in just 2018. Down below that list, you see 2 schools of osteopathic medicine. These schools grant the Doctor of Osteopathic Medicine or DO degrees. If I were to look back just 8 years, 3 schools would be new. Our one and only UC Riverside that admitted its first class in 2013. Again, California North State University as a for-profit medical school and then in 2018, California University of Science and Medicine. And you have several statistics in your written item that show dates and fees and location for these schools. Next slide, please. So here is our map, and I'll say again, this is largely for today. But if we were to look forward to the summer, to August, and then to September, we would see 2 new California medical schools added to the map. The first is the Kaiser Permanente Bernard J. Tyson School of Medicine that's located in Pasadena, California. The Kaiser School of Medicine will admit its first class in August. This is a nonprofit school of medicine. The school will admit 48 students and has waived fees for the first 5 classes across all 4 years. The second school to open, I think in September is the date, is California Health Sciences University. And this will open as the second for-profit medical school in the state of California as an osteopathic school of medicine, located not far, see the star above UCSF Fresno, not far from our UCSF Fresno medical education program. And further out, but without dates, are 2 proposed schools. We learn about this as applicants file and register themselves under applicant status with the LCME, signaling their intent to seek accreditation. So the 2 that at least I and our team are aware of are that Charles Drew University, which is a longtime partner and has operated a longtime joint program in medical education with the UCLA School of Medicine, has signaled its intent to also open an independent 4-year medical school while still continuing its commitment to the joint program at UCLA. And then the Keck Graduate Institute in Southern California, with no date noticed, has also filed for applicant status. Next slide, please. So I mentioned at the start of my comments that California has the 4th lowest medical student on a per capita basis in the nation. As we take a look at where our California doctors have attended medical school, just to look at this through a slightly different lens, we see that 24%, and this is medical board data, have attended a California medical school. Most of the newer schools don't have graduates through residency training and into licensure, so this would be a look at what has been a long time statistic for the state. Again, roughly 1/4 of California doctors coming from a California medical school, UC in the longstanding privates. Another 49% attended other US medical schools, and then roughly 27% are graduates of international schools. Next slide, please. Now to the role of our own UC medical schools. Our 6 schools of medicine, I think, play major roles and distinctive ones with top-ranked programs across our missions of education, research, and public service. Collectively, we train more than 3,500 medical students and roughly 5,200 medical residents and fellows. This is nearly half of the state's total. Across our health professional degree programs and our, which include programs in nursing and pharmacy and vet med and dentistry, roughly 2/3 of this total health sciences enrollment come through our medical students and our medical residents. And then I think important to note, and we look at this in the context of medical education, is that although California is at the bottom among all types of medical schools in opportunity for students, our state ranks at the very bottom of all states in terms of enrollment in public medical schools. And so this you see is further than fourth lowest. This is really puts us at the bottom with 8.8 slots per 100,000 in our public UC medical schools. And this is compared to other public medical schools with a median of 21.3. And I think this last point is important for us to consider, given the prioritization our health sciences schools and our medical schools have in prioritizing the recruitment and admission of California students and the diversity we seek, the diversity that we need in this state to improve access, equity, and health outcomes. I'll say, and I didn't include a slide, but could have, that with our entering classes, with our enrollment for 1920, our UC schools have 31% of our students are those who are underrepresented in medicine. Although this does not reflect the diversity of the state, this compares favorably and highly to the US average. And then by contrast, for the state of California alone, our UIM numbers are just 23%. And I and my team work together with the admissions deans of our longstanding private schools to look at our applicant pool, our admitted students, our enrolled students from the standpoint of diversity. In addition to the overall diversity for 1920 class, I would point out that if we look at our UC Prime programs, these are our programs in medical education with roughly 350 students. Our level of diversity across 6 programs jumps to 64%, really a model in terms of a framework for enhancing the diversity of our future physician workforce. And you'll have a little opportunity to hear a bit more about the San Joaquin Valley Prime program in the item that follows. Next slide. So I included this slide just as a quick point of reference to show that for the 1920 year, nearly 53,000 students across the country applied for admission to a US medical school. And this was for a total of 21,869 slots in the same year. In the written item, again, you will see detail in terms of the striking volume of applicants, driven strongly by the interest of California students in seeking admission to UC medical schools. We know that we hear from many students who are so disappointed to need to leave the state when their priority or preference would be to attend a UC medical school. You have the detail in terms of the volume, but I would say this ranges from 5,900 applicants to our newest School of Medicine, UC Riverside, that prioritizes students from this region for a class of just 77, to a high at UCLA of 9,825. The average across our medical schools of individual applicants is about 7,411, and this is seeking admission to just 789 first-year slots. So you see the competitiveness and the drive and the interest of California students. Roughly 60% of our students in the 1920 year who were admitted to medical school could not be accommodated within the state, but are top-ranked students in medical schools across this country. And then again, sort of as context, apart from our Prime initiative that was launched in 2004 as a strategy for enrollment growth, but without state investment, we hit the Great Recession of 2008. And with the exception of the launch of our new Riverside School of Medicine, the UC system has seen virtually no enrollment growth in medical education in more than 40 years. And in the face of huge population growth, huge high school graduation rates, huge increases in the numbers of California applicants. So next slide. I'm going to move now briefly to talk now about residency training. Medical students graduate from medical school. Our classes have all just finished through virtual graduations and a drive-through virtual graduation at UCI to enter residency training. So we refer to medical student education as UME. We refer to residency training as graduate medical education, or GME. This slide, this donut shows California as a whole with 11,646 residents and fellows enrolled in 1920. You see the distribution for the University of California campuses on your right, totaling 5,200, or roughly 45% of the whole. So we are thus a major contributor in the graduate medical education arena. The remaining 55% are spread across a variety of sponsors statewide. And these sponsors include our private, longstanding schools of medicine. Some of the newer for-profit schools and some of our osteopathic schools don't operate their own clinical facilities, hospitals, and sometimes are not sponsors of their own GME programs. Kaiser Permanente is also a long-time major sponsor of graduate medical education. We also have freestanding children's hospitals and community hospitals, and then a few others. Next slide. So as we contemplate our medical student education system, together with our GME programs in the state, I think there are so many outcomes for us to be proud of, those of us within the University of California, but those of other leaders in the state. And this is our state ranks first in the nation, so bottom of the nation in terms of opportunities for medical education in public schools, top of the nation among all states with the highest rates of retention of residency program graduates that we train in this state. You see a few sub-bullets that follow. There are many of these that are published by the AAMC that give us an opportunity to look at different combinations of training sites and places. Among our practicing physicians who I described briefly at the start, among those who complete residency training in the state, 70% remain here, which means even though we're a small contributor overall, 25% go to school here or have received training here, we overwhelmingly succeed in retention. Among our practicing doctors who graduated from a California medical school, this number is 62.8%. Among those who graduated from a UC school, this number climbs. And this is again because of the overwhelming prioritization in the admission and recruitment and admission of California students. And then when we pair these together with opportunities for California students to go to medical school and to train here, our numbers jump to 80%. And I guess the observation from that level of success is that this is not only California student serving, this is really California population serving. We like to begin conversations with a focus on the patients and the people who we serve. And as a public university, I think these are some outcomes that we should all be proud of. Okay, next slide, and heading to just a few that are remaining. This slide shows the decisions of our graduating medical school classes just over these past few weeks. And what you see, we use a term match. This, when our students are preparing to graduate from medical school, they enter a national resident matching program that enables them, as well as the residency programs, to match one another to programs for training. And here I think is you see another measure of the focus of our schools on the people of California. So for our 6 schools, you see high rates of match to residency programs. This is all residency programs in the state of California. You see high rates of match also within our own system, with many students ranking UC programs, but our GME system is not large enough to accommodate necessarily all of those students, but high rates of match either at the same program where a student could have graduated from Davis and looked to match at UC Davis. I also might have ranked and matched at UCLA or UC San Diego, but very high match rates. And then those matching in primary care where we have dire need as we started to observe, we see high rates of our students selecting primary care. And interestingly, these have climbed, I think, in the last decade. Next slide. So I'm going to quote from a line from a message that President Napolitano included in a note that she sent to the Office of the President community just yesterday. Dr. Byington had a similar comment. But in President Napolitano's note to the Office of the President, she wrote that world events have given us a vivid picture of what is not working. And I think for all of us here in this committee today, we would agree that that's so true. The impact of our workforce shortages has been longstanding. It has painfully revealed the importance of an adequate workforce, not just physicians, but other healthcare providers. We have seen steady erosion and lack of sustainable investment for medical education. And this in turn has really been a barrier to expanding educational opportunities for our students and expanding GME training. And although there isn't time, I would point to recent investments in GME for our state, including Proposition 56, which is a partnered program with the University of California that creates a resource from tobacco-related revenue for expanding residency training opportunities statewide. And yet we continue, so I remind us here that we are at the top of the nation in retention of those who we train. Our own UC schools have extraordinary rates of contribution and retention, and that really the return here is for our students and the people of the state of California, who so many of our graduates are preparing to care for. And then to the last slide. I mentioned briefly the final report of the California Future Health Workforce Commission, again, co-chaired by President Napolitano. And she and Dr. Sandra Hernandez, President and CEO of the California Healthcare Foundation, and I had the opportunity to present to the HSC back in April and 19th at a high level, the recommendations, the approach to work, the guiding vision. There's not time to go through this again, but importantly, as part of that presentation and as part of the final work of the commission's report, there were three that pertained to medical education. This commission was broadly constituted. It included leadership from higher ed, from our delivery system, with broad support from the philanthropic organizations. I think as members of the commission looked at the outcomes, some of which I've tried to summarize briefly here today, this formed the basis of their voting and recommendations regarding medical education recommendations at our public medical schools, which are UC. In short, the commission recommended full funding for our PRIME initiative, which has not occurred, but is moving along exceedingly well. The commission highlighted, I think, the vital need for an increased sustainable investment for the Riverside School of Medicine at $25 million a year in permanent ongoing operating support. And it highlighted the value of investing in an expanded partnership between the UCSF School of Medicine, our UC Merced campus is our newest, and our longstanding UCSF Fresno program, as an opportunity to build an expanded branch campus in the San Joaquin Valley. The governor's budget included this proposed $25 million for UC Riverside. We were pleased to see this. It also included a $15 million in ongoing support for an expanded effort, again, in partnership with UCSF, UC Merced, and UCSF Fresno. We were so pleased to see this, and you'll hear much more about this in the item that followed. We were happy to see that the budget plan that was passed by the legislature just a day or two ago includes both of these items, both for Riverside and for UCSF, UC Merced, and UCSF Fresno. And I guess I would wrap up here, but I would also like to close by personally thanking in behalf of also so many, President Napolitano for her leadership of the Future Health Workforce Commission, for her steady partnership and engagement on issues impacting the needs of many of the poorest communities in this state. We did a lot of work related to the San Joaquin Valley and a lot of work in support of UC Riverside. So I'm just my appreciation for that. And then I guess my own hope is that as we look to the future, my hope is that the governor will include these two actions in a final state budget for the state of California, and that these will be legacies going forward for the people of this state and in light of recent challenges. So I'm happy to stop there, and we'll welcome any questions. Our deans are here also if there are questions that relate to this, or I'm out the press of time. Thank you.
Thank you. That was an excellent report, and for me, quite informative, because I was surprised at where we were ranking in some of these things. I'm going to call on Regent Park, and then Anne, if you can get student observer Noah Denish ready to speak. And then I'll go to Deborah Dees after that.
Okay, so you want Noah to speak after Regent Park?
Yeah, after Lark, I think, because I just want to get him queued up. Okay.
Yeah.
Thanks.
Thanks, Chair Lansing. So thank you, Dr. Nation. I have a few questions for you and or Dr. Byington. So I was wondering, what can you tell us about the cost to produce a primary care physician or a psychiatrist? And maybe you can only speak from the UC perspective, but what can you tell us about the cost to actually produce, both primary care physician and a psychiatrist?
So Dr. Byington, do you want to lead off? I'll add, or how would you like to do that?
Sure. So I know Dr. Nation is leading a group looking at the cost of medical education. I have done work in that area in other states, and it is, in my experience, roughly $100,000, $106,000 to get a student through medical education. And so the funding of that education has been increasing over time as we change the model from single professor to address an entire class to a model where we have more active learning and small groups and more professors that are needed, and especially on the clinical side. So that's why the relationship between the hospitals and the providers in the hospitals who may act as professors is so important with the academic side of the house. And Catherine, I don't know if you have any data specifically for the UC system about the cost per medical student.
And just to clarify though, those do not include residency costs?
Right.
Or they...
Correct, that's for undergraduate medical education.
Right, so what can you say about sort of the full cost, right, that includes both medical school and residency, right? You're starting from somebody who has gotten a bachelor's, and you're accounting for all the costs of educating them, including, the clinical practice up until, they're receiving.
Are you asking for the cost to the individual trainee or student, or are you asking the cost to the institution?
I'm asking about the cost more generically, so definitely not the cost to the student. You can account costs that students pay as incoming. What is sort of
For you, it's a good one.
the cost of production, so to speak?
Right, production, I don't know if I can speak to the entire cost. We did an analysis in Utah looking at the cost to get someone to the first faculty position. So that would mean undergraduate college experience, medical school, residency, fellowship, and now they're a faculty member. And that was between $2.5 and $3 million for a pediatrician. It is a substantive investment to train individuals through a period of 12, 15, 17 years.
So for me, it would be interesting to be able to, if you or your staff could point to any resources that really allows us to understand then those costs of literally producing these professionals. I don't necessarily count undergraduate costs per se in this because, we think that there's sort of a wide population who get bachelor's degrees who then want to go to medical school. I guess my second question, and it is somewhat related to the first, and I know you've been thinking about this, Dr. Byington, is how can we innovate, right? To whether it's to lower the cost or speed up the time. We are looking to the state, we're looking to other sources to fund the cost of producing these medical professionals. But, what can you say about the state of really innovating the whole, not just curriculum, but sort of the pathway, so to speak, of producing these medical professionals that are desperately needed, for which I think, it's going to be hard to for the state to sort of step in as much as, the kind of gap that we've identified by 2030. And also the runway time to all of this is considerable, right? I mean, we only have like a couple of years really to say, like, if we want to try to fill the gap more within California, we'd have to come up with a plan that we could execute in about 2 years' time to try to reach that 2030 goal. So my second question is about what would you say about the state of innovation here?
I believe there is incredible opportunity for innovation in the University of California system partnering with the state. And you have a system that includes phenomenal undergraduates. Some of those undergraduates already know they want to be physicians. They could be targeted early and guided into our training programs. I think there needs to be discussions about what type of work can count in an undergraduate setting that may actually be useful once you enter medical school, and the same medical school for residency. Looking at it as a continuum rather than as a discrete time unit. So I don't believe that every undergraduate should take 4 years to finish college, and that every medical student must have 4 years to finish medical school, and every medical residency must be a certain number of years. So I'm very interested in innovations that look at competency-based measures rather than just time-based measures. And there's an opportunity across the UC system because you own the entire continuum from undergraduate college level to undergraduate medical students to residency. So there is an opportunity if we bring all the stakeholders together for innovation.
And I would add to that, and I want to be mindful of time. I know that we have a speaker and an action item and lunch guests, so would absolutely welcome the opportunity to follow up either at a next meeting or between meetings with some additional information. But we do have our deans here and on the call, but I would say that I'm going to agree that there is a lot of innovation. I'll point to one. We have an accelerated competency-based program at UC Davis that is essentially takes a year off of the continuum that Dr. Byington just pointed out. I share those views that Not all students require 4 years to complete medical school. Some do. Some may opt to complete a master's or may take 5, but we have many who are ready to go beyond. And for the Davis program, the Davis program recruits a small number of students who are ready, who are primary care focused. Those students complete their medical education in 3 years and move on into residency training in primary care. This is regionally focused and intended to benefit the greater Sacramento region. So this saves those students a year of fees and a year of time. And there are many other examples, but I'll just point to that one. And a commitment to come back on cost of instruction. The cost of instruction group that we have looking is medical student education, but agree that it needs to be joined up with the cost of residency training. So.
Dr. Bayan, did you have anything that you wanted to add to that?
I was just going to say that I believe there are opportunities to work with the state in a different way because we are the public institution. And I think particularly in the area of 4th year medical students who are very close to their being able to be licensed physicians, and allowing them to work in settings that the state has identified as underserved could produce a win for both the state and the student. The student gets exceptional experience under supervision. There may be an opportunity for loan reduction, and then the state has providers that they wouldn't otherwise have to reach particularly difficult areas. So these are ideas that I would like to bring a group together across the system to talk about. It was really top of mind on our December strategic planning session, and then January the pandemic started. But I'd like to bring it back to top of mind. So
are there any opportunities with the private sector or others within healthcare proper entities that might be considered competitors in a different context? Is there an opportunity to collaborate with other California institutions, not just the state?
I mean, you see, as Dr. Nation mentioned, Kaiser Permanente is starting their own medical school. Why are they doing that? Because they want to train their own providers and they want them to understand their health system. We have an opportunity to train providers for other health systems and to have them be stakeholders. We are training the workforce. And so to work with health systems in the same way that you would imagine working with the military, for example, that someone is identified at the time of training, that they're going to go into your system, they're going to be matched to your system. That takes off a huge amount of pressure as well for the student. I've talked about it before, the number of interviews that our students go on and the costs that they incur in the end of their medical school training. If they already knew from the beginning where they were going to go, all of that would be saved.
Okay, and then one just quick question, last question for Dr. Nation, since you worked on the Future of Healthcare Commission. So within the write-up to this item, it's referenced that we can't really, or we shouldn't really be relying as much in the future on importing physicians into California based on the high costs of living, et cetera. And it pointed, the footnote was to the commission's report. I was wondering, is there particular data that the commission looked at or trends that they were able to see directly about the sort of the reduction in the ability to recruit out-of-state physicians?
So I will need to look at the data, but most of the analytic work,
You're good.
Okay. Most of the analytic work was related to the commission recommendations, was undertaken by UCSF Health Force, which is one of the leading workforce centers in the nation, and far and away the strongest in terms of the state of California, because many of our California foundations have funded UCSF Health Force to do county level analysis and work with the medical board. So they have a rich and growing database. I believe, in short, this was a look at the growth in the number of designated health profession shortage areas. An observation perhaps about cost of living. We know that we send far more California students out of state to go to medical school than would otherwise choose because our system is small. Not all of those students come back. So I think it is that the observation that in-migration is no longer a reliable strategy comes in the face of the fact that we're losing ground. We have more and more people without access, shortages that are growing by type, primary care and non-primary care, and then a workforce that is really about to be reduced substantially with a wave of physician retirements. But I'll take that note and look back at what the data is.
Thank you.
Is that it, Regent Park?
Yes, thank you.
Thank you for your questions. So can we have student observer Noah Danish, please? Hi, Noah.
Thank you so much. Thank you so much, Chair Lansing, and thank you to Dr. Nation for this informative update on medical education. I'm Noah Danish, a student at UCLA, and I wanted to start by also saying thank you to Dr. Byington. During the past health services meeting since December, I believe your presentations have been extremely informative and really focused on how we can better the UC health system for students. So thank you. And as Dr. Byington mentioned today, COVID-19 has been impacting every community across the country, but it is particularly magnifying some of the disparities in our healthcare system, with Black American patients in the U.S. twice as likely to die from COVID-19. Medical education is a very tangible thing that we can make an impact on. This stretches from opening up the opportunities for even more diverse classes to increasing the inclusiveness of the academia we put out. As an example of that, Dr. Jenna Lester, a dermatologist from UCSF, found that the scientific articles on COVID-19's effect on the skin is nearly always shown on lighter white skin. By having articles show the effects on skin of different colors in addition to white, we can help improve diagnoses and outcomes because the doctors that learn from these articles are exposed to the array of different ways this skin effect could manifest in their patients. I think this research by Dr. Lester is just one highlight of showing how the medical education and research we do here at UC, which publishes so much of the medical research around the country, can work to improve healthcare for everyone. And we can reach this goal by helping increase representation and opportunity in healthcare. As this report by Dr. Nation mentioned, fewer than 10% of California's physicians identify as Latinx or African American, even though these groups make up over 40% of our state population. I think the report from Dr. Nation also did a really great job at highlighting the issue of distribution of physicians around California. I wanted to echo this point of increasing medical school enrollment, capacity, and residence training because it is a fundamental way of giving the best students, no matter their background, the opportunity to enter the field. I believe that even with the budget cuts from the states, the UC and the regions should make it a priority to advocate for the funding of increased class enrollment. I would also like to see updated reports about what the demographics of medical schools look like, and that can help us inform of our progress in this regard. As we saw from the reports today, having the data accessible is really the foundation to make the changes we need to. I think it is extremely important to prioritize advocating for the adequate funding for expansion of medical education in the San Joaquin Valley and Inland Empire, which item H3, which is coming up, we'll discuss, and the important expansion into these communities. Funding for these programs is just one of the few endorsed budget items this year by the UC Student Association. Maintaining funding for UC Riverside and funding for expansion into these underserved communities is the start for increasing access to healthcare in these communities. But I hope that we also focus on the efforts to retain these physicians in these communities. And I'm interested to see not how we just maintain and increase retention, but not in just California, but throughout our underserved communities. And on top of that, as Regent Park just mentioned, it's really extremely important that we can look at innovative ways to change this pathway and make it more flexible for students as they're going even from the undergraduate process. The earlier we start, I think we have the potential for the best results. In regard to the current medical school process, I believe we should be doing more to help the current pool of applicants. For example, as Dr. Byington mentioned, the interviews are often really strenuous on students. They need to miss class and need to fly around the country. Another large part is the cost of applying is application fees. So with primary and secondary applications, this can pile on to become thousands of dollars for students. And this is money that many of our students, especially now, don't have access to. And this could really deter them from seeking medical education. The UC could look at being a leader in reducing these fees. It's especially important now during the pandemic, but it's also important even beyond, because this fits in line with our goal of recruiting the best students regardless of their socioeconomic background. And that's my main comments on H3 and H4. I briefly wanted to comment on H6. I'll keep this comment brief. As our campuses are reopening, students coming to campus are going to be completing symptom checks. But given our increasing understanding of the high rates of asymptomatic cases, I believe we should work towards increasing accessibility to COVID-19 testing on campus and near where the students are. Students should not hesitate getting a test if they feel at risk. And during the last health services meeting, we spoke about the high cost of testing, but in tandem with price coming down and avoiding severe outbreaks, it's clearly extremely valuable to our students, faculty, and campuses. And personally, with my experience at UCLA, Chancellor Block and the vice chancellors have been great at communicating developments with the students. To increase communication here and across the UC, I think it would be beneficial to see similar statistics on how many UC students are being tested and their rates of positivity, similar to the accessible statistics on testing that we see coming daily from UC Health. If students better understand and feel more educated about what's going on right around them, we can remove another stressor that students are facing while on campus. And one other consistent point that I've discussed over the past meetings is the importance of telehealth for students. Since some students will not be returning to campuses in the fall, I believe we need to continue to build our robust telehealth services for physician appointments and mental health care appointments. This will allow us to care for the health of our on-campus students, but our students who stay around the country and around the world also have access to the amazing physicians and staff here at UC. And with that, thank you so much to the committee. Thank you to the UC Health leadership. And thank you, Chair Lansing, again, for giving me the opportunity to share some perspectives here at the committee.
Thank you, Noah, as always, for your intelligent and thoughtful comments. We really appreciate you and your participation. I have three more speakers before we go on to the next item. And then after the next item, we'll break for lunch, just to give everybody an idea. So Deborah, do you want to go, followed by Sharp? I'm calling you all by your first name. It's the privilege of Zoom. I can say Regent Settle and Steve Hetz, whatever. Those are the three speakers.
Of course. Thank you.
I think on Zoom, the first name is better.
I like that.
I do too.
Thank you. I'm Regent Lansing. I just would like to comment and first of all, thank Catherine for an excellent presentation. 2 points from the presentation that really struck me, and I feel that we really need to put a lot of efforts into. One is the disparity in the number of underrepresented physicians that we have in California, less than 10% Latinx and African Americans. I know that the UC schools, medical schools, have been doing a great job. In a presentation that I did at our retreat last year, I indicated that all of the UC medical schools back in 2019 enrolled at least 30% underrepresented in medicine physicians. And I expect that we will continue at that rate and hopefully greater. However, with Latinx and African Americans representing 40% of the state population, we really have to address that disparity. At UCR this year, we will be enrolling 50% of our class as underrepresented in medicine. Therefore, we need to increase the number of available positions for our medical students. The second point is that by 2030, we will have less than 2/3 the number of psychiatrists that we need. And although we have programs in the state that support residency training and retention of physicians, psychiatry is not qualified for any of those programs, namely Proposition 56 and Song-Brown. And I really feel that we as a system must communicate with the state to change some of the legislation around that, because psychiatry should be a primary care specialty. And if we're looking at by 2030, 2/3 of the psychiatrists needed, we will not have, something has to be done. And while we are attracting many students into psychiatry, because we don't have these retention programs, it is likely that those students may be leaving the state afterwards, or leaving the state after training. So I think that's something that we may need to have discussions about at a future date.
Thank you. Regent Settle?
Thank you, and great presentation, Catherine, as usual. Just wanted to ask a quick question. We haven't mentioned allied health professionals such as nurse practitioners and physician assistants. Do we not do anything in that regard to help maximize and support the MD care?
No, so I appreciate that question. And absolutely we do. When we had initially planned for this particular item, we had imagined, we were talking about this item in February, and we had a tentative time for April. And this was pre-May revised, but it was intended as one to bring folks up to date about the vital importance. And we hit pause in light of the pandemic, in light of the state's financial woes. Just recognizing time, there wasn't going to be enough time to give a meaningful presentation on all of the professions that are across our UC system. Dr. Byington and I would like to bring that back more broadly. The final report of the Future Health Workforce Commission spanned the professions, advanced practice nursing, registered nursing, pharmacy, and others, including those programs where UC does not participate. So I had the opportunity at the president's request and at the request of Chancellor White, who heads the CSU system, and Eloy Ortiz, to chair a public higher ed steering committee where we collected an inventory of educational offerings from the community college system from CSU, which helped inform some of the recommendations of the commission. So there were recommendations, including only one that I'll mention here in the interest of time, and it goes to Dean Dees's observation about the mental health crisis. And this was not in lieu of the vital need for expanding opportunities for the Song-Brown Commission. I have a governor's appointment on that commission. I know it well. We will be revisiting the discussion of psychiatry at an upcoming policy meeting. We will also be revisiting the question of psychiatry for purposes of Prop 56. But recognizing the long timeline that Regent Park pointed to, we had a top 10 recommendation in the commission that I think was extraordinarily innovative, which was to join three of our 4 UC schools of nursing together in putting together a psychiatric mental health NP credential for already practicing nurse practitioners in the state, and have some positive news in terms of funding from California Healthcare Foundation to get it started. That whole effort aimed to prepare 300 providers, again, already practicing NPs with a 12-month curriculum, online and in residence, to get to the issue of vital need, geographic distribution, savings of cost. So absolutely yes to the wise question about the need and focus of providers more broadly than physicians.
Thank you.
Steve Hetz?
Yes, and I'll keep this brief because I realize the hour is late. I just wanted to thank you, Dr. Nation, for your really insightful comments. I wanted to say that, on behalf of the Academic Senate, we really look forward to working with you on this innovative approach to the continuum of medical education. And I think your comments about UC being a major participant in all phases of that is really important, as echoed by Dr. Byington as well. And it's very encouraging hearing, Dr. Diaz's comments about psychiatry. And I think we'll need to look at the definitions of what counts as primary care and what doesn't. And the role, as Regent Zettel said, about other health professionals, because really I think we need to take a step back and look at disease-focused and population-focused needs in California, and those are going to require solutions that are not for just MDs or DOs or NPs, but the real continuum of health providers. And so I really look forward to us working with you coming up to come up with intelligent solutions to serving the population of California across all of these different health professions.
That is our last question. So thank you. We are really running behind. So I'm going to now ask Dr. Byington to do item H3, and hopefully, I don't want to stop any discussion. We can do that as scheduled in 15 minutes and then take a 10-minute break to get our lunch. And then Dr. Byington, our speaker, I know we've allotted quite a bit of time for that, but maybe we can shorten it by 10 minutes or so if possible.
We'll do our best. Thank you, Regent Lansing. So we have an opportunity now to hear a tangible way that we can increase medical education in our state. And so Executive Vice Chancellor and Provost Canfield and Dr. Hurd, would you please join us and give us your presentation on the building proposed for the Merced campus?
Thank you so much. I am only going to briefly have my video on. I've been having bandwidth trouble, so I'm going to have to send myself back to the picture of me in the mountains hiking. I want to thank you all for this opportunity. As with the item on Davis, what we're asking from you is approval to go ahead to the Finances and Capital Strategies Committees for planning funding for this building. And the stars have recently aligned around medical education in the South. It's a deeply underserved region for medicine. And one of the reasons that we were put in the San Joaquin Valley with adequate funding to actually participate in medical education, we've instead been building capacity. Our psychology program is focused on health psychology and actually spun off our public health program, which postdates the planning for our 2020 project. And we also have worked very hard on developing capacity to understand differential needs among different communities in our anthropology department and our sociology department. So we have a great deal of expertise in culturally competent community engaged projects, helping communities improve health outcomes without medical intervention per se, but much more in terms of public health interventions. So I think we have done, we've also developed a tremendous capacity in biology and in bioengineering. So we have basic science and also applied science and healthcare concerns. So we have done a great deal to prepare for participation in medical education. And with a change in the landscape and understanding of the state's needs, it became pretty clear that now is the time for us to push forward. We have collaborated with UCSF, with their Fresno branch, and my very first serious high-level hire, the effort to develop medical education in partnership with UCSF. So Dr. Hurd, please. Is she on?
Dr. Hurd?
Dr. Hurd?
Huh.
If she is on mute. Let's
No,
see.
I don't see her on the participant list. I think she needs to be let in from the waiting room.
There's no one in the waiting room.
Well, then I guess I will take this
Please
forward.
continue.
Please,
Yes.
I'll send her an email.
Okay, thank you. You know, in some ways, what we are doing here is simply recapitulating what you already know about the San Joaquin Valley. The building that we're proposing is not just a medical education building. It is also to accommodate our public health program, which, as I mentioned, was only an idea when we were planning for 2020. So it really didn't get into those construction plans at all. So we need the facility as well as for medical education. And with respect, it's a question of simply growing, the campus growing. We need more general assignment classrooms as well. So if you could have the next slide, please. See if we can move through this. I know you've all read this material. What we're looking at here, and this speaks to some of the other questions that came up earlier about different ways of managing medical education and the real importance of growing your own. The importance of finding the people who are committed to the Valley, who are part of the Valley, who have the diversity of the Valley, really coming into medical education is what we're starting with here. And we have this idea of a combined Bachelor of Science and MD degree. We hope to bring students into the front end of that on our campus in 2023. And eventually we'll have the first 18 months of medical school on our campus. Now, to my mind, that's a fantastic opportunity. And again, when we're talking about innovation and education, because UCSF has an extraordinary curriculum. It's problem-based. It's very different from the traditional kinds and ideas of education, which is mostly fact-based rather than action-based. And for our faculty, a third of our Senate faculty are excited to participate in medical education. This would include a significant retooling of their abilities as pedagogues when they have to first learn about the UCSF curriculum. I think that will in turn be pulled back into our undergraduate curriculum. So what we're looking at here is a seamless approach to education that is very patient-centered, very problem-based, and I think will be a radical improvement in the way we do medical education. I don't think I need really to go over the planning phase here for you. Again, I'm fully aware that I'm between you and lunch, but if you have particular questions, come back to that. So next slide, please. I hope you can hear me. I'm being told my internet can, there we go.
No, you're perfect.
We've worked pretty hard on developing, excellent, thank you. On developing a program. This is where Dr. Hurd was really influential in terms of what the building would look like and what it would include. It fits in with our long-range development plan very nicely. You see the approximate size we're looking at. And as I mentioned, it will house psychology and public health as well as medical education. And what we're looking at here is a state-of-the-art digital anatomy lab. So a very novel approach to doing it on substantial simulation environments. These are high tech and really valuable for innovation in education, as well as distance learning teaching spaces. Because again, we're going to be in collaboration, not just with the Fresno branch of UCSF, but with UCSF as a whole. And for our ability to connect our students and our faculty across that very robust and important system is important to us. And the Child and Family Development Research Lab is really a part of our insistence that the work we do is connected to the community. We have done so much community engaged scholarship already, but one of the big challenges we've had is easy access for the community to the campus. So the location of this building will be on a new access road that the 2020 project gave us with parking and appropriate wayfinding and access to the community. And sort of covered that. Next slide, please. So here's the timeline. We are feeling the need to make this happen quickly for obvious reasons. We've had a profound sense of disappointment in the San Joaquin Valley that we've not been able to create medical education as soon as was desired. And we know the needs are pressing and increasing with the aging of the medical population. So the degree to which we can be a part of the solution is very important to us. Next slide, please. And there you can see the 2020 project close to completion. The first slide was at substantial completion. What we're really talking about here is the next phase. This building would allow us to
I think we lost you.
I think we may have lost him.
Yeah, I think we lost him. Can you continue with it? Oh, we don't have the slides, though. Well, we have it in our book, a lot of it.
The slides can progress, yeah.
Okay, Dr. Byington, do you think you can continue?
I don't know.
Okay, I understand.
Catherine, do you think you
This is the
could?
last slide.
I don't know how many more slides there are.
That was the final slide.
Here he comes. He's back.
Okay, we lost
for
you.
growth in our undergraduate
He's back.
population.
I think we've lost you. Are you in a bad internet? Are you there? Oh dear.
We're having a very hard time hearing you. I don't know if Teresa has joined.
So I believe that Dr. Hurd, she joined initially via YouTube, and the invite with the Zoom link has just been sent to her. So hopefully if she sees this in the next minute, she'll join us via Zoom.
I'm sorry about that.
Chair Lansing, we've had so much information in our board.
How many slides are left? Because I agree with you. We have all the
That was the last
information.
slide. That was the last
That was
slide.
the last slide. All right. And that's the last slide. So
I think really then maybe it's just to move it forward to see if there are questions which we could take back.
okay, so
to
let's just can I have a motion to move this item?
So moved.
Can I have a second?
Second.
Okay, now, does anyone have any questions? Because I do not see any raised hands.
There we go.
Lark.
Okay, Thelma Hurd is coming in now. If you want to wait a sec or just move on, I'll let her in.
Let her in, please, and maybe if there are any questions that we could answer.
Region Park has a question.
I do, and I don't know. It sounds like Greg is still trying to talk. He must.
Yeah, I'm going to try and mute him.
That was the last
Hello, I'm finally able to access the meeting.
Okay, great. I know Region Park, I got your chat that we could.
Really, that maybe it's just to move it forward to see if there are questions which we could take back.
Okay, so let's just, can I have a motion to move this item?
So moved.
Can I have a second? Second. Okay, is anyone opposed? Anyone have any questions? Because I do not see any.
I have a few questions, Sherry, and maybe I can just sort of say what they are and then.
Yes, no, I want Lark, I got your chat, but I'm afraid I'll lose a quorum. So,
Okay.
so I don't want to rush this through. It's an important item. So I think we are able to answer Lark's questions, and that's the only hand that I see raised, but I don't want in any way to feel that anyone has to not raise their hands. Right now, all I have is Regent Park. So Regent Park, we will attempt to answer your questions.
Okay, so I have three quick questions. The first one is how can you ensure that this investment will actually translate into better healthcare for the community, right? More, I understand sort of the growing of the research and moving of the departments, but at this point in time, given what has been highlighted about the dearth of professionals and the lack of access, how can we really ensure that this investment is going to have that sort of direct, not immediate, but direct near-term benefit to the community in terms of improving access to healthcare and health outcomes? My second question is, it looked like there was an inaugural class of 12 identified. That seems really small. It looks like it's trying to ramp annually, but are there ways to increase that inaugural class so that we can grow the program in a bigger way sooner? And then the last question is really on the 300-person lecture hall that is part of the design. We're not going to be living in COVID forever, but people have really started to question this idea of the need for these really larger lecture halls. Is it really necessary? I know that there are lots of different ways about that benefit, but those are my questions. I don't need to have answers to them now. Sherry, if you want to move this along, I will vote.
Well, let's see if anyone can. We have time, so can you answer these questions? And if not, I'll ask you to answer them offline. But I'd like to see if we can answer them now.
Did you want to take this?
Dr. Hurd, you're on mute. If you could unmute, we'd be happy to hear you. Dr. Hurd?
Can you hear me now?
Yes.
Yes, we hear you and we see you, Dr. Hurd. This is great.
Okay.
And the last question.
Okay, so the first, I was getting feedback from 3 questions, so I clearly heard the first one, which was how, and the first question is
Can I ask
the response.
But those are my questions. I don't need to have answers to them now.
Okay.
Sherry, if you want to move this along.
No, so let's see if anyone can. We have. And
I'm getting dual, triple.
She's getting dual. Okay, everybody mute, please.
Turn off her.
Dr. Hurd,
Everybody mute.
Dr. Hurd,
Everybody mute.
if
Dr.
you are
Hurd needs to
watching
turn
the,
off her Zoom, her YouTube situation.
if you're watching the webcast, you have to mute the webcast in the
I
background.
am muted. I am muted. I will stop my video. Maybe that will help. I am unmuted.
No, the webcast, if you
I
have
can
the
hear you,
webcast in the background.
And I am unmuted, muted. Okay. So the first, I was getting feedback from 3 questions.
If you have the webcast in the background, you have to mute that. YouTube,
Michael,
if
can you
you're
let
watching
her
the
know to
YouTube
turn off the
webcast,
YouTube?
that needs to be
Turn
muted.
off the sound on your computer so you stop hearing the, or off the video stream you're watching.
Okay, perfect. Let's see if anyone.
I'm getting dual, triple.
She's getting dual. Okay, everybody mute. All right, let me take the. Can everyone please?
I'm on.
Okay, this is something what I would like to do. Hello, can everyone stop? What I'd like to do is Regent Park, can you, well now everyone's on mute. Dr. Hurd, unmute yourself and please answer the first question, and then Regent Park will ask you your second question. And if that doesn't work, I have another alternative.
Okay, can you hear me now?
Yes.
Can you hear me now?
Yes.
Can you, not using, you can hear me, Ms. Lansing? I mean, Chair
I
Lansing?
can, but
You can hear me?
unfortunately, Dr. Hurd, I think we better, you're getting a lot of feedback. I think you're both on YouTube and this. What I'd like to suggest, okay, now go on mute again, please.
Yes.
Everyone go on mute, me.
So remute, and I'll take.
All right, everyone,
the
please
question
go on mute besides me, please. All right. Obviously, there's something wrong with the connections. So what I'd like to suggest with your permission, Regent Park, is what you initially suggested, that you will get an answer to these 3 questions during our break. Maybe you can send her a phone call that Regent Park can get the answer to the 3 questions directly. And then because of a quorum possible loss, we have a move and a second and no other questions. So with that said, can we have a roll call vote? And then I don't want to in any way have Regent Park have to vote if she needs this information to vote. And then I can hold it open because I know that she'll be here for the rest of the meeting and let you on the break get the answers to your questions. And assuming that will work, then you can vote whichever way you want to after the break. But I'm afraid of losing some people for the quorum. So is that all right with everyone? Anyone object? Okay, so can I have a roll call vote, Ann?
Yes, Regent Goober.
I'm not sure what we're voting on.
We're voting.
Item H3, do you have that in front of you? Proposed request for approval of the Health and Behavioral Sciences Building, Merced Campus.
Okay, yes, I approve.
Goober, yes. Lansing.
Yes.
Lansing, yes. Napolitano.
Yes.
Napolitano, yes. Park.
Yes.
Park, yes. Perez.
Yes.
Perez, yes. Sherman.
I can hold it open.
Yes.
Because I know that she'll be here.
Sherman, yes. Zettel.
Yes.
Zettel, yes. Motion is approved unanimously.
All right, I'm really sorry to have to done this, especially to Regent Park who had the questions, but I appreciate your yes vote. So if you can either have your questions answered during the break or set up a time where Ann will send you how to get in touch with Dr. Hurd and have all the questions answered whenever it's convenient for both of you. This is the failure of technology, but it's one of the rare times that it doesn't work. So we're going to take a 10-minute break and no longer, because we're very, very, very far behind. Fortunately, I don't need a quorum for any of the others, but I do want your participation because they're very, very important items. They're not action items. They're discussion items before we go into closed session. I don't want to limit any of the discussion items. After the presentation by one of our doctors in the speaker series, we're going to go into items that are planned to take an hour each. So with that said, I'll see you back here in exactly 10 minutes. Do not get off your link. Please keep it.
Just a reminder, that'll be 12:38.
Okay. Well, let's make it an even 12:40. I'll do that. Okay. But be back. Okay. Thank you.
Dr. Hurd, this is John Bettis, the chair of the board. If for some reason you are both in the Zoom call and watching this by webcast, that may be the issue. So,
I'm not, I can no longer, I went out of, I logged out of YouTube. I closed the window and left that window site. And I can see you through Zoom. That's how I'm logged on, is through UCOP Zoom.
but here's what I would suggest is maybe you disconnect from the Zoom as well, shut down and restart your computer because there's something else playing in the background beyond the Zoom.
Okay, I will log off now, and then you want me to relog back on?
So I would shut down all the programs that are up and running on your computer.
Okay.
And then log back in, and hopefully that'll limit you to one feed, just the Zoom feed.
Okay, and
I guess down, sorry, never mind.
Okay, thank you. Before, I just want to welcome everybody back and just say that while we're enjoying our lunch, so we will be eating, we're not being rude, we'll be listening attentively. We have the great gift of incredible speakers, and I'm going to let Dr. Byington introduce them to us.
Thank you so much. The speaker series is a tradition of our Health Services Committee meeting where we hear from faculty engaged in exceptional work across the system. Today, we have the opportunity to hear from two delegations from UC San Francisco who traveled first to New York City and then the second delegation to the Navajo Nation to deliver care during the COVID-19 pandemic. Our first presenter is Dr. Lundy Campbell, who is a cardiac anesthesiologist and critical care specialist at UCSF. And our second presenter is Dr. Sri Shyamsunder, who is associate professor of medicine at UC San Francisco and director of the UCSF HEAL Initiative. Dr. Lundy will speak first, followed by Dr. Shyamsunder. And I'd ask that we hold questions until both speakers have had an opportunity to present. Dr. Campbell?
Yes, thank you. I'd like to start and start by thanking everybody for this opportunity for me to talk. And I think, are my slides coming up? I don't see them on the screen yet.
Can we have Dr. Campbell's slides, Mike, please? The slides are up, Dr. Campbell.
Okay, great, thank you. If you can go to the next slide, please. So I was part of a delegation that went to New York during the coronavirus crisis here, and we went to New York Presbyterian. And the first thing I'd like to talk about is why New York, and I think we all know that New York was hit very hard, much harder than California was and anywhere else in the US. What's interesting is we started at about the same place in California and New York, but there were some decisions that were made in California, which I really have to, I really want to, state that we did a great job. We closed down about 6 days, closed the state down about 6 days before New York did. Actually, we closed San Francisco down 6 days before, and then the state of New York 3 days before New York. And that made a huge difference for a couple of reasons. Probably the density of New York City versus California, and also their subway system and that. There was some question about whether or not we would actually be able to go to New York or not, because we were concerned about what was going to happen in California. There was a lot of people that wanted to volunteer to go. And then when the decision was made to finally go to New York, we only had a couple of days notice, which made it so that there wasn't as many people that were able to go as really wanted. But getting back to why New York, New York had about 200,000 cases, was over 16,000 deaths. And the numbers you've got here, which I put in just a week ago, are actually a little bit old, but Queens County in New York is still number 2 in total of coronavirus deaths. And their current is around 5,200. At the time we went, it was around 4,700 to 800 or so, behind Kings number 1. And then in cases, they used to be number 2. They're now number 3 behind Cook County and LA County, but they are still sitting at around 63,000 cases over this time period. Next slide, please. So the initial phase of who went to San Francisco we sent 9 nurses. All of them went to New York Presbyterian Queens. And of those nurses, 4 of them were from the ED department. And then the other 5 were intensive care unit nurses. We also sent 12 physicians in that initial phase. And these were for an entire month. And of those, 8 went to Queens Hospital. And that was 4 hospitalists, 2 critical care physicians, an emergency medicine doctor, and 1 anesthesiologist. And then 4 went to New York Presbyterian, Cornell, and that was 1 emergency medicine doctor, 2 critical care physicians, and 1 anesthesiologist. 2 weeks later, we sent a second wave where we sent 1 physician, a cardiologist to Cornell, and 2 more physicians to Queens, an anesthesiologist and another critical care physician, and a New York nurse practitioner also to Queens Hospital. Next, please. The state of Queens, when Queens Hospital, when I arrived, was quite interesting. It's the largest hospital, New York Presbyterian Queens, the largest hospital in Queens. It's about a 500-bed hospital, or staffed beds. They had been having about over 100 patients a day coming into the emergency room for the past week or 2, really. And at that point, they had over 700 patients in the hospital, all of which essentially were COVID positive. Of those patients, they had approximately somewhere between 110 to 120 on a daily basis in ICU level care. The hospital itself is only staffed for 40 ICU beds. So that left quite a few patients in these kind of makeshift ICU beds, which included putting patients in the recovery room, any sort of holding areas, and they even opened up the cafeteria as a makeshift ICU when we were there. There's still another, if you do the math, you'll find there's still probably another 10 to 15 patients or so. And those are patients that were just on the regular hospital ward that were intubated and sedated and critically ill that we couldn't even get them into one of the makeshift ICUs, and they were just basically placed with every other patient within the hospital. Next, please. So what did we find and what lessons were learned from this, from our trip there? Well, 1, our PPE works. Everyone who went was tested negative for both the virus and the antibody upon their return. And so we all had essentially no exposure to the virus. There was an overemphasis on personal protective equipment and ventilators, however, and you still see that within the news. People will say, you know, oh, we're making so many ventilators, we're gonna have all these ventilators in the stockpile. We were not short of ventilators, but what we were short of was medications, dialysis machines, and other key equipment, and then physical space. What was probably most critical were key personnel. We were short, we had ventilators, but we did not have respiratory therapists who could run those ventilators. We had some dialysis machines, not nearly enough, and you'd have to go through every day and prioritize which patients might get dialysis and which ones wouldn't, even though, so let's say you had 10 patients in your ICU that needed dialysis, maybe you could dialyze 2 on a daily basis. So you had to make decisions based on who you might dialyze today. But we had a shortage of nurses who could actually do that dialysis. And then the thing that became most apparent to me was that here I am in New York City in a very good hospital, and any healthcare system can be overrun and function as a resource limited center. And it felt more like some of the global health missions I've been on, where I was vastly short of personnel and vastly short of equipment. And the same could happen here in UCSF or anywhere within the University of California system, given the fact of the number of patients that came in. Next slide, please. So some reflections about how this experience went, and this is a picture here of the ICU physicians, both local and those of us who went there to help out, and not just from University of California, but also from some other places within the US. I think we were able to help the local physicians in a big way because we were able to work within their system and rotate within their ICU and relieve those local physicians and nurses from some of the stresses that they were under. And just to put a put some emphasis on that. There are very many physicians and nurses who had not seen their family in over a month because they were afraid of bringing the virus home. So they basically took their kids and sent them with their in-laws, or they lived in an apartment somewhere else for a month the entire time that we were there because they were afraid to go home. The 1 month that we were there was a good time frame. It was long enough to work into the existing healthcare system, and it was short enough to really prevent burnout. And the burnout is really an issue. This was a very difficult experience. There was a lot of death. I had patients die on me every single day that I was in New York City. And that kind of left a lot of us with a feeling of just helplessness and not a lot of hope. It was also very challenging because family members couldn't see their loved ones. And so you'd have to call them every day and tell them how they were doing. And they couldn't really understand what you were telling them because they couldn't really put a face to that. They couldn't really see what was actually happening. And most of them were very concerned about where their family member would go once they died. The likelihood of death if you were intubated within that healthcare system was somewhere between 80 to 90%. So the death rate was very, very high once you were very sick. Last slide, please. So I've had some follow-up with the people that are still there, the locals, and as I talked about, everyone that, as we were tested, everyone there was also tested, and they have also been negative as well, which is good. At Queens, they have now closed down all their makeshift ICUs. There's only 2 actual COVID units that are still running, and the providers are finally getting back to their normal life, seeing their family and doing things that they would normally be doing. All of us that went would agree that we would all go back again. And to keep this relatively short, because I know you're behind schedule, I'll stop there, and we can, if there's time for questions later, I'll take them. But I think Sri has the next presentation.
Thank you so much, Dr. Campbell. We appreciate it. And Dr. Shamasunder, if you're ready, we will start your slides. I believe you might be on mute.
Oh, sorry. What a privilege to speak to all of you, and thank you, Dr. Byington and Dr. Nation for inviting me, and Mark Laird for suggesting me. I am very much a product of the UC system. I graduated from Berkeley, and Prop 209 was passed during my freshman year, and I graduated from residency at Harbor UCLA. And so I'm grateful for my education through the UC system. I wanted to just take a moment to acknowledge the land that I'm on, currently in Oakland, the Ohlone land, and in our Navajo Nation delegation, as well as in all the work that the UCSF HEAL initiative does. We take a moment to acknowledge the land of the Native people that are the past, present, and future stewards of the land. And that allows us to ground ourselves in humility and service. Next slide. So I think one thing I wanted to ground ourselves in is a little bit about the HEAL initiative, which is a UCSF Global Health Fellowship Program. And it's important to understand that context in order to understand the delegation to Navajo Nation. And so when I finished residency at Harbor UCLA, I thought my training in UCLA would make me effective in working in underserved communities around the world. And so I worked in Haiti after the earthquake. I worked in East Africa. We worked in Liberia during the Ebola outbreak. And what we saw is so much needless death over and over again. And I realized that I wasn't skilled enough and didn't have the training, even though I went through med school, went through residency, to really be effective in these underserved contexts in meaningful ways. And then the colleagues next to me that are from high impacted communities often were amazing despite their medical education instead of because of it. And so in 2015, we started this program in the UCSF HEAL initiative. And the real organizing principle is, how do you immerse yourself proximal to suffering and start to transform yourself in order to get better at serving underserved populations. And so we've been around at UCSF for 5 years, and we've had 149 health professionals, frontline health professionals. Half of them are US doctors or nurses, and a quarter of them are Navajo, and another quarter are from countries from around the world, like Haiti, Mexico, India, Nepal. And so this really diverse cohort that comes together. Next slide. And so I won't go through the whole HEAL model right now, but it's really based on deep partnership with impacted communities that are trying to serve the underserved. And it is selecting, this is at the end of training. So nurses are fully trained, physicians are fully trained that join this program, and they're partnered with Native communities, in this case, in Navajo Nation, with a one-to-one match. For every US doctor or nurse that comes through, there's also a Navajo health professional or somebody from Haiti. And we depend on US government contracts with Navajo Nation. There's a huge vacancy rate at 30% workforce vacancy rate of jobs. And so we fill those jobs and use some of that funding to run our program. And continue. And so this, on the bottom, you can see the different countries, and we've been working in Navajo Nation for the last 5 years, and we've been in 19 partner sites and 9 countries. Some of the impact that we've had, the non-native health professionals that have joined our program, over the first 3 years of our program, 30% of them have stayed and been retained in Navajo Nation. And there was a US government report that said UCSF HEAL is a strategy to retain folks. And the native health professionals have really gained leadership positions after the fellowship and been retained also in their communities. Next slide. So a lot of folks may not know where Navajo Nation is. It is 27,000 square miles across the states of New Mexico, Arizona, and a little bit of Utah. And in the bigger picture, you can see the different regions across New Mexico and Arizona, Gallup, Fort Defiance, Tuba City, Shiprock, all of these places that the UCSF delegation went to. Next slide. So we heard from New York, and currently Navajo Nation is the hardest hit area per capita in the country. There's now over 6,200 cases and nearly 300 deaths in Navajo Nation. So incredible amounts of suffering that is coming on already an underfunded health system and a community that suffers at baseline. Next slide. And so in, I think the context of our partners being partnered with Navajo Nation for the last 5 years, we started to hear as the COVID surge increased in Navajo Nation that they really needed nurses and critical care nurses, emergency room nurses to serve the Navajo population. And they were having to shut down units. They were having to co-locate COVID positive patients and COVID negative patients. And so we went to the UCSF leadership and we said, you know, can we have access to nurses that might want to volunteer? And that was on April 12th. And within 48 hours, 70 nurses volunteered to sign up to go to Navajo Nation. And on April 22nd, we had our first wave of UCSF volunteers that joined the 51 HEAL fellows that already existed in Navajo Nation. And then there's a second wave that came on late in May. So there's been over 40 health professionals that have come from UCSF to stand shoulder to shoulder with our Navajo colleagues in this incredibly difficult time. And so we're across 5 facilities in Navajo Nation, New Mexico and Arizona. And we're doing work I was rounding in motels where there's COVID patients that are homeless, that are COVID positive, got put in a partnership with the New Mexico government, got placed in hotel rooms, motel rooms, and in order to protect them as well as the community. And so we were rounding on those patients in the motel, 175 of them that were either COVID pending or COVID positive. And we were taking care of respiratory care patients that were very sick in the hospitals. And as you may know, that there's only a few ICU beds on Navajo Nation. So many of the patients, when they're about to get intubated, they're going to be transferred off their native land, and they're getting sent to Albuquerque, Phoenix, Flagstaff in order to continue their care. And so sacred land, they're getting sent oftentimes to be, even more isolated in larger cities. Next slide. I think it's important, as the conversations have been in the first part of our discussion about what it looks like in California and the disparities of COVID laying bare how much people of color, Black communities, Native communities have all been impacted disproportionately. And in Navajo Nation, you can't talk about diabetes and obesity without saying that there's only 13 grocery stores on all of Navajo Nation, where the size of West Virginia, there's 162 grocery stores. And so there's 30% of the population doesn't have running water or electricity. And so where isolating in place might be inconvenience for us, it's an impossibility for a lot of our Navajo patient population. And just to also mention that there's been systemic underfunding of the Indian Health Service, where they're funded at 1/3 the rate of the VA or Medicare per capita. Next slide. And so, some of the conversations earlier today about the diversity of the workforce in California, I think HEAL, this is our HEAL community. As you can see, it's made up of Native members, and it's made up of a lot of Black and Latinx health professionals, as well as health professionals from all over the world. And so it's really this incredible way to learn together how to take care of underserved populations. Next slide. And I wanted to just share a couple vignettes of some of the work that we were doing in Navajo Nation. And one patient that I took care of, there was a 59-year-old woman who is Navajo and in Chinle, Arizona, which is right on the middle of the reservation. And she was very sick. She came in on high flow oxygen, and she was speaking to me through broken sentences as she was trying to catch her breath. But I took care of her for a week in Navajo Nation, and every day I would go in, I was in my full PPE, and she would tell me the story of her life, as well as her getting sick. And the 2 weeks before she came into the hospital, she was getting sicker and sicker, and she lives with her 85-year-old parents. And so she, in April in Arizona, it gets cold at night. It's a desert. And so she set up her pickup truck, laid down blankets, and had fevers and chills for 2 weeks in her pickup truck with a couple of blankets on, in order to not expose her family members from getting sicker, right? She didn't want to expose her elder parents. And so I think two of the lessons that we held so much, and we heard time and time again, and we experienced, was that the deep respect for elders. So you have communities living with multi-generational home, and oftentimes if there's one bathroom, the most senior person, the grandmother, is getting that bathroom in order to shelter in place. And then the other piece is the resilience. This woman typifies the resilience of Navajo people and Native Americans, because she was sick and she was having fevers and chills, and she was just kind of like toughening it through. And so whether or not we were there, this is a people that really have, whether outsiders are paying attention or not, have shown resilience over and over again. And then the two colleagues that you can see on this picture, Dr. Begay and Dr. Tom, really HEAL and UCSF are running a sprint to stand in solidarity with our Navajo colleagues. But these women, physician leaders, Dr. Begay is a HEAL fellow. She's the head of ambulatory care at Gallup Indian Medical Center, and they are running the marathon. Dr. Begay has not seen her grandchildren in months, is really leading. And she came on chancellor calls with Chancellor Hawgood and Mark Larrett to discuss, what UCSF and HEAL are doing in Navajo Nation and how we can move forward in solidarity for the long term. And so there was this real deep partnership between Dr. Begay and UCSF senior leadership. Next slide. So I know we're short on time, so I won't go through this slide, but as HEAL thinks about its next steps, we've been in existence for 5 years, the solidarity effort in Navajo Nation. I think there's a few ways that are relevant to the entire UC system. So we hear over and over again from people that join HEAL that after their medical school, after their residency, nurses, this is coming back to a social mission in what it means to be a health professional. And so we about 17 to 18% of our health professionals in HEAL are Latinx or African American, and another 25% are Native American through our partnership with Navajo Nation. So as we try to build the California health workforce to match the demographics of California, I think UCSF HEAL initiative is one of that can inform, how do we piggyback on the pipeline programs that already exist to really anchor in an amazing amounts of Native, Latinx, and African American workforce. And then I think the last thing that I'll say that could inform us is that the way that we partner, I think the trust in COVID times is not built in the moment of a crisis. It was formed through the HEAL partnership before, and it was solidified. And so as we think in our academic institutions, how do we partner and how do we live in solidarity with our most impacted communities? I think the site fellowship model that HEAL has, where we're really building the Navajo capacity to speak and work and take care of their own population, is one example of what we might lean into in the UC system even more, because we know that COVID is laying bare both the inequities, and then we're in this other crisis of racism in this country that we need programs and leadership that allows us to lean into this moment. Thank you.
Thank you so much. Thank you both. Regent
So-
Lynch?
Yes, I just want to say I was extraordinarily moved by both reports. We always say that our mission is to serve the underserved, but these are two real examples where we went to New York because of the crisis and the lack of healthcare workers and really served. And we also know that the Navajo Nation is one of the great inequities in healthcare, as we heard earlier, and we've been made aware of through numerous articles. It makes me very proud of the work that UC Health is doing. I think what you said is so true, that the relationship was built before, and that's why the trust was there when we came in. And I should say when you came in, because I wish I could come in, but I don't have the skill set. But a lot of times we sit in these meetings and we hear a lot about what's going on, but to really see the direct impact on what UC Health and our physicians and healthcare workers are doing was incredibly moving to me and incredibly inspirational. And I'm now going to call on Regent Settle for her comments.
Thank you so
And
much.
Thank all of you also.
Thank you. Amazing presentations. I am too inspired by your compassionate care, and thank you very, very much. So proud of the UC family, and in particular here at UCSF. I have a quick question. Dr. Campbell, you mentioned the lack of dialysis machines, but most importantly, dialysis workers who could operate these and so forth. We know that a lot of the deaths have been from lung problems and pneumonia. How was the interplay of diabetes and maybe lack of dialysis care? How did that work into that death picture?
Sure, that's a great question. We've really found that patients that have COVID, especially when they're critically ill like that, go into multi-organ system failure. And the kidney is one of the first things that kind of goes out in most patients. And you see that even if you just have garden variety pneumonia here, from whatever else, bacterial pneumonia, whatever else. So we see that pretty commonly. In COVID, it's even probably at a higher rate because patients would kind of come into this like extreme inflammatory phase where the whole body is basically almost attacked. And so we had a lot of patients that would go on to having renal failure. Now, the interesting thing, kind of what Sri was saying, is that there's we saw in Queens, the majority population around the hospital is Asian, but the majority of our patients were Latinx. So it was interesting, and I think there was some, not 100% sure why, whether it was genetic versus or there was more coexisting disease in that population that we probably thought was a lot of the case. And so we do know that patients that come in that have diabetes, that have some other major medical problems, are at much higher risk of dying from COVID than another patient who isn't quite as healthy. And we did see a fair amount of patients who were young, 40s and 50s, who were dying from this disease. Certainly patients in their 80s and 90s when they got it were high risk of death, but even fairly young patients, we even had some 30-year-olds that were not doing well, and they had coexisting diseases. So obesity, diabetes, hypertension, those are the things that really led to a poor outcome.
Thank you.
Can I actually take the liberty of asking a question before I move on to the next speaker? When you said what you said, I was really struck by the question as to whether we hear always in the news that age, 89% of the people who died were over the age of 70, or I'm off on the statistics, but you know where I'm going. Mm-hmm. And my question is, has anyone ever done a study, because it may not be age, but it may be the underlying diseases that people have. As you see more 30 and 40-year-olds dying of the disease or going into ICUs, the question I'm asking, is it age related, or is it related to the other illnesses that you have, diabetes, lung, kidney, all of that? Has anyone done a study on that yet, or are there studies being proposed on that?
Well, I think it's not specific. I'm not aware of a specific study on that, but if you look at populations and you were to say, okay, who has these major diseases of diabetes and hypertension and heart disease and everything else, it's going to be in the older population, right?
Absolutely.
So they're very intimately tied, and that's hard to break those two out. The one thing that I would say that was a huge, there were so many things that were wrong with what was happening in New York, and one was no reaction on the federal level of anything that was going on, right? But there was this huge missed opportunity to look at these patients, do autopsies on them, and figure out why these patients were dying. Very little studies were actually being done. We were looking at remdesivir and some of those things, but a lot of stuff was not done because they were just so overwhelmed, and there was no response from the federal government to come in and say, let's start studying what's happening here and why are these patients dying, because that's equally important to keeping the next phase of patients alive. And that was a real problem. But I think the best answer to your question is both. I think it's, the older you are, the less likely you're going to have less physiologic reserve, so you're not going to be able to handle a huge insult like COVID may give you. But the real problem is these underlying critical illnesses that people have that then they can't recover from when they get COVID.
So I'm just going to let it go there, but Dr. Byington, we do a lot of research, at our medical centers, and now you have a huge database of people, unfortunately, who have died from this disease. And I guess as somebody who's in the at-risk population, because of age, not all people above the age of 65 are the same, this is not about me, but it's about that population that I'm forever defending, saying, we're not old, so to speak, we're all different. And I think it would be very interesting to see, of that population, people who did not have underlying diseases, how they fared with the disease, whether they had minor symptoms. You know, I can tell you anecdotally, I know a lot of those. I also know a lot of people who are in ICU because of it. But I think we've always done age because we've assumed that people over the age of 65 have all these comorbidities. They don't. We know that. They may have more of them. But my question is also to protect the 30, 40, and 50-year-olds who are thinking that they're completely going to beat this disease and it's nothing for them to worry about, refusing to wear masks, whatever. It might help educate them as well that comorbidity, perhaps, I don't know what the data is going to say, is a bigger cause than age. And I just want to throw that out. I'm not telling anyone to do it. It would be a very interesting study to pursue. And it would free up, you know, those who are more at risk, and not just saying that people of a certain age should shelter, but it may be comorbidity people should shelter. You understand what I'm saying? I've talked too much, but it really fascinates me.
Well, anecdotally, I think in Navajo Nation, because the family clusters were so impacted, where there was sometimes 4 generations of families that were all hospitalized. I took care of young, like 40-year-olds whose grandmothers had COVID but did okay, you know, and then they were close to getting intubated. So you do see that where it's not completely based on age. It has to do with comorbidities. And you know, I think if people that are 40 and 80 that have no comorbidities on population level, the 80-year-olds might get sicker, you know, and have worse outcomes compared to 40-year-olds with no health problems. But I think if you have a 40-year-old with diabetes or obesity, they often will do much worse than like a healthy.
An 80-year-old that has no comorbidity. Right. Well, I'd say it would be interesting to evaluate the sheltering by comorbidity, not just by age. But I leave that to you to decide whether that's worth pursuing. Mark Larrett, next.
Regent Lansing, I just want to put a little context around these presentations today. When the team came to Chancellor Hawgood, Dean King, and myself to ask for permission to go, we thought we would learn some lessons if we could find out how others have been impacted that we could bring back to UCSF and across the system. And I think what we not only learned those kinds of lessons, we also have become incredibly inspired by the bravery and the courage of these individuals and the whole teams. We saw them off at the airport to go. And by the way, United Airlines provided free flights. Avis provided free cars. There was an enormous amount of support. But seeing these brave individuals leave their families, not really knowing what their future held, but understanding that there were needs that they were far greater than what they were dealing with at home, and that they put themselves in that line of fire to go out and protect others. I don't think we can adequately express the intensity of the experience that they've had, and frankly, from UCSF standpoint, our gratitude for the courage that they've shown and how they've reflected so well on the university.
Thank you.
Gary, you're on mute.
Unmute me. Okay. Beautifully said, Mark, on behalf of all of us. I think you expressed it so eloquently, what we all feel. President Napolitano, you're next.
Well, I'd like to just echo what Mark said. You represent the best of the university, and I think we're all not only inspired, but grateful for what you did. Dr. Shamasundar, one of the questions I had is, how did you deal with the language issue on the res? Navajo, as we know, is an extraordinarily difficult language, and many people there only speak it, particularly the elders. So I'm just curious on how you dealt with that.
Yeah, that's a good question. I think that was a big gap in like really understanding the community and some of the patients, but we leaned on a lot of the Navajo nurses, the Navajo nursing assistants. There's too few physicians that are Navajo. A lot of these sites, they are really, there's like Dr. Begay and some others are the only ones. And so, I would sometimes I had some patients with like chronic uranium lung disease that had COVID, and I would be speaking to them, and then they would look over, and then the Navajo, nurse would tell them something that I had just said in their own language. And so you can see the importance of language and trust that is hard when you have kind of a lot of outsiders coming in. And so language, and plus the PPE, and you're wearing masks, all of that makes it incredibly difficult. And then so I would say the language barrier is crucial. In the motels, we had Navajo nurse assistants with us at all times, and so they kind of are supporting us. And so we've worked in Navajo Nation but obviously don't speak the language, and so really leaning on our Navajo colleagues. And it's mostly the elders, like the current grandparents in Navajo Nation have almost fully gone through being like boarded, going to boarding schools, like forced boarding schools. And so there's a variation of how fluent people are in English and how much they only speak Navajo, but many of the elders are only comfortable in Navajo.
But you were supplied with assistance and the like as you were providing care.
I wouldn't say supply, because there's a workforce shortage there. So you try to do your best, but you're trying to bring on, every time you go into the room, everybody has to don full PPE. So especially people that don't speak English, you're bringing in your nursing aides and nurses that speak Navajo, because that's crucial. But oftentimes you're making do. And then obviously there's no patients at bedside to translate at all. So that's another, real barrier. And I think that's similar, a little bit different, but similar to what our non-English speaking patients currently in the UC system are dealing with, where English is, they don't speak English, and their family's not at bedside, and they're more isolated than ever.
Yeah. Okay. Thank you.
John Perez, Chair Perez.
Thanks. I want to add my thanks to both of you. And I really do think that it's incredible that we went into both of these communities. There was clearly a national focus on an epicenter in New York. There was not the same national focus on the crisis in Navajo country. And for us to step in and address that, I think, is really important. I think what we're also hearing is the importance of language and cultural competency in the delivery of healthcare, and how important it is for us to continue to move and make improvements in all of these areas. I do have a follow-up question, perhaps for Mark and Dr. Campbell combined, because Dr. Campbell, one of the statements you made was that when you looked at the community around the hospital, it was significantly API, but when you looked at the patients you were treating, it was disproportionately Latino. And the reason I'm asking Mark as well is because UCSF did a study did outreach in the Mission District in San Francisco, and even post-gentrification in the Mission District, 90% of those who were testing positive, if I'm right, Mark, were Latino, even in an area where the population was now less than half Latino. 90% of the positives were Latino. And then of those that tested positive, regardless of race, I think somewhere around 90% were folks who were in jobs that required them to work outside of the house, even during stay-at-home orders. And so I'm wondering, Dr. Campbell, if you saw a similar pattern, not only of demographic population that looked different as a community, but was that reinforced by experiences, at least anecdotally, of these disproportionately being folks that worked out of the home?
That's a wonderful question. And I don't have an answer to that because by the time that these patients got to the hospital, they were so sick, you weren't able to kind of get a real good social history on them. And because their families were not able to join them at all, you really couldn't see that. I think that what I've seen at UCSF of the patients that have come into the UCSF, that has been the case. We've seen people that were Uber Eats drivers and these kind of things, and that tend to probably be around people more and are not sheltering. I would imagine that's probably the case in New York City as well. I really would. It was, but I don't have the exact answer for that.
Because I think this is one of the things we have to learn of, and I think the question that Regent Lansing asked is important in terms of age versus comorbidity. I think it's also true when we look at different demographic groups, how much of this is comorbidity, how much of it is a combination of comorbidity and being put in positions of greater risk for exposure, and the interplay of all those things that we have to look at over the long term. So I thank you.
Well, thank you. And that's a awesome, a way to look at it, I think. It's something I didn't really think about, but that's fantastic. Thank you.
Sherry, you're muted again.
Gracious, someone muted me without telling me. So they probably heard me eating. And at any rate, I started to say those were great questions. And so I'm going to have Regent Butler followed by Regent Park, and then Regent Bhavani, you can have the last word. And then on as much as I'd like to spend the rest of the afternoon talking about this, that will be it. And we thank you enormously. Regent Butler.
Thank
Lafonso?
you. And just as a incredibly important part of my thanks for the work of both groups. I found the reports to be incredibly inspiring and really, really insightful. My question is to Dr. Campbell. Specific to the HEAL initiative, you made some reference to the social mission HEAL initiative, and I think implied and the demographic diversity. And can you talk a little bit about, can you unpack that a little bit if you are indeed stating that there is a correlation between social mission and diversity, and then if there are lessons that are being taken from the HEAL initiative and offered around the system, diversifying our medical profession.
Awesome. Thank you. So I think that with HEAL, one of the things that we hear from Black and Latinx applicants, because they're finishing up residency and they want to join programs like this. This is oftentimes, they saw their communities impacted by poor health outcomes disproportionately, and they understand this, so viscerally, and oftentimes being in significant amounts of debt is a barrier. So loan repayment is something that we've tried to start to think about for people that, right now we have a woman from Southside Chicago that grew up, a Black woman who's an OBGYN, and she's a HEAL fellow that splits her time in Navajo Nation, working as an OBGYN, and in rural Malawi. And so she spends her 2 years as a HEAL fellow like that. And so she really believes that HEAL, the understanding of how to serve an underserved community is going to help her take care of the Black community as she goes forward, right? And I do think that many of the health professionals that want to do this, there's a real barrier by debt. And I think a lot of the Latinx population and the African-American population that really want to do something like HEAL, we have about 17% that join HEAL, but many more don't join because they're just straddled by debt and can't, by the time they get out of residency, they have a lot of obligations. And so I do think that social mission is something, when you're in a community that is holding these values, it becomes the norm rather than the aberration. And so you're anchoring back in these values that frankly, like med school and residency sometimes take you away from. And when you start as a first year med student or first year nursing student, all the medical school essays are like, I want to serve the underserved. And then oftentimes as you finish your training, you kind of either are in debt or you don't know how to find that community. And so finding that community of like-minded health professionals holds you in a container to drive, I think, the social mission. And so for California, I think these programs are so crucial because, whether we're talking about Merced or Fresno, it can have a pathway forward for people from those communities to continue and not be brain drained out of them and continue to serve those because it becomes the norm rather than the aberration to that.
Thank you, Dr. Shamasunder, and I apologize, Dr. Campbell, for directing that question to the wrong place. Thank you so much. I appreciate it.
Unmute. Thank you, LaFonso. Alark, you're next.
Thanks, Sherry. And again, thanks to the presenters for really inspiring presentation that really shows us, again, what public service is all about. So I wanted to go back a little bit to the comments that Chair Perez made about sort of the other kinds of circumstances other than just underlying health disparities that we may see. But I was really struck by what Dr. Campbell, what you had said about that context, right? About who's in the community and who's showing up in hospitals. And it really struck home for me how so many of at least the underlying health disparities are sort of slow motion accidents in a way. They take this long time. They severely hamper people's quality of life. It may not kill them instantaneously, but we somehow, collectively allow this to persist, right? Because it's not this immediate shock, and then comes COVID, and it's no longer slow motion anymore. It becomes sort of, the car crash, so to speak, and that sort of gives us an even stronger imperative that we can't really let those underlying conditions just fester within our communities as we've been doing. And then you weren't part of this meeting early on when Dr. Byington made her remarks about convening a retreat in July and highlighting health equity and health disparity and what the UC system can further do, in this regard. But I would really love to understand if you have a perspective based on your, both of your experiences about what the UC can further do in its own backyard to work with the communities of color, especially the African American community, which has been so hard hit by this, and that we have to do something now. We can't study. I mean, yes, we can study the issue, but that's not a sufficient response. So any just thoughts from you based on your experiences working in the field and working with populations you have about the things that are really ripe for discussion when Dr. Byington convenes all of the health executives in July?
I can start. That's an excellent question. I think, given especially how hard hit Oakland has already been and is likely to become, and then also in LA, I think, it seems to me that a lot of chronic health issues that we see are, you're right, they're kind of swept under the rug, even by the people who have them, right? We think that, who cares about high blood pressure? You don't feel it, but if I take this medication, it makes me feel awful. So why would I bother treating it? And the same goes for a lot of other, diabetes, all this stuff. And you can see that, especially like in the African-American community, diabetes is such a major problem. And they got very hard hit in New York, in the Bronx. I think that I would think that our role in this is to really educate people that, these things, while they while we may have thought of them as something that could kill you in 10 to 20, 30 type years, isn't the case. And that when these things pop up, that we uncover these chronic health issues that can become deadly tomorrow, and kind of give more a sense of urgency to people to treat these effectively, to for the individuals themselves to take this on themselves and seek out treatment, but be able to hopefully provide that treatment to them and go out in the communities and give more treatment of this and more education about this.
Just to add quickly, one of the things that HEAL has tried to do is, like, at every level of, we talk about, there's a principle of like preferential option for the poor, or preferential option for Black and Latinx populations, right? And so that means that if you're going to focus on equity, it has to be it can't be like equal offerings. Like, you have to anchor in the principle, because from HEAL's perspective, if we give the same opportunities to Navajo fellows as well as like a doc from Michigan, who takes advantage of that and who thrives is very different. And so you have to, from the governance standpoint, I think from the budgetary standpoint, how do we anchor in these communities? And I think, like at UCSF, the Black Caucus is leading us in conversations around police violence and Black community in Bayview, Hunters Point. There are already local leaders in those communities that are driving the conversation. And so how do we bring them to the table and bring them into the conversation? Because sometimes, I know in Navajo Nation, usually the partnerships are like, UCSF or others coming in for a short amount of time. But if you're building a deep partnership, they need to be part of every step of the conversation. I know UC has a track record of trying to do that, but how do we do that more systematically? Because every institution across UC has deeply impacted Black and Brown communities. And are they in these conversations to guide the answers? Because, with HEAL, we're not driving the solutions in Navajo Nation. We're paying attention to what our partners are saying. And like President Napolitano said, they speak Navajo, they know the community, they're driving the answers. And how do we leverage this incredible higher education institution on behalf and in collaboration and in solidarity with them, rather than thinking that we have any answers in our own containers.
Sherry, could I just comment on that? It ties Regent Park to what you were talking about in innovation, and what can we do? And what I hear both of our speakers talking about are principles of community engagement, principles of community empowerment, and being able to stay present for the long term. We have the advantage of our students and our trainees. We can bring them to these communities, and we can create infrastructures where they can learn and where they can thrive and where they can give service. So that's the type of work that I'm very anxious to begin to engage in as we move forward.
Kumkum, you have the final word.
Thank you, Chair Lansing, and thank you to both of you for these very moving accounts. As many have said, kudos to all of you, and of course to UCSF for allowing you to go and for supporting you in that. And for seeing how important service is. All of us in the UC are very happy to stand by you, and as the Academic Senate stands really close to you in trying to work out how we can support you in all that you're doing at the moment and will do in the future with communities of color and people of color within the university. My question is initially to Dr. Shamasundar, but maybe Dr. Campbell will also want to chime in. But you were seeing patients who are suffering, and this is from structural inequalities, and yet this has to be tackled at an individual level, individual by individual. And all of that can cause a lot of challenge and stress for people who are working in this way. And we often see ourselves there. We know that it is only good fortune that separates us from the people we're working with. How did you deal with that challenge and stress as you're there, as you're together, supporting people who need much more help than you do, and yet we all need that support as well. Dr. Sundaram, I wondered Dr. Shamasundar, I wondered what you thought.
Yeah, I think that community was a big part of holding the space to have difficult conversations. And I think that this was one of I think as you go on your training, I think that you see a lot of suffering. In COVID, you're both proximal to suffering, you're at risk yourself of getting infected, and you're seeing a lot of needless death. And so I think this was the professionalism of keeping a distance. I think for most of us broke down to the point where it was pretty, there's things like Schwartz rounds, which is this great tradition of sharing hard things in medicine. And so you would have Navajo colleagues be on those rounds and talk about not seeing their grandkids for months. You would talk about them being at the breaking point and potentially thinking about having thoughts about dark thoughts, and so I think that being able to share that as in the health professions was one strategy. And HEAL, for all the volunteers, had held calls 3 times a week, and it was kind of a principle of HEAL that you can't do this alone, and you shouldn't do this alone. And pain is halved by sharing it in some ways, and so it's not going to go away, and you have to be able to just hold it. And so I think it's really trying to have individual practices of whether it's meditation, exercise, whatever, but then also holding it as a community. And I think UCSF made available to us a faculty and staff support psychologist that had held calls on Sundays. The leadership, Mark Laird and the chancellor got together with the whole volunteers. So there was this space that was held for the suffering that we were witness to. And as you said, it sometimes feels guilt-ridden that we're suffering because we're seeing much more people in much more dire straits, but there is an importance to hold that for all health professionals. And I think both the partnership with HEAL did a good job and UCSF, but that's, it's still a difficult thing.
Thank you. Thank you. So I, as I said, was incredibly moved and inspired. And I guess from my point of view, it reminds all of us of why we're doing what we're doing. So I have done a terrible job of being chair and of managing the time. This initial item was supposed to take 45 minutes, and I tried to say I would reduce it to a half hour, but sensing how important it was to all of us in the context of the work that we hope to be part of, it's now gone a full hour. So I have no regret about that. I thank both of you so much, and I thank Dr. Byington for bringing this forward to us. It really does remind us of why we're here. So I am going to now move on reluctantly, because I think a lot of us would like to sit and talk about this forever. But thank you both for the work you're doing, and thank you, Dr. Byington, for bringing this forward. I'm going to go to item H6, and then we have that scheduled for an hour. Depending on where we are at the end of that, I guess I'm going to ask Dr. Byington whether we should shorten at H7 or whether we should do it at the next meeting. I think I just want to be mindful of the presenters, that all of us are very conscientious and we have read everything that you've sent us. So I'm not trying to in any way inhibit the discussion. I think most of us can stay easily till 3:30. It was supposed to finish at 3:15. Beyond that, I think you're going to lose a lot of people because I'm getting a lot of emails saying that. Okay, so Dr. Byington, back to you.
Thank you very much, Regent Lansing. And we will now focus on H6, which is the fiscal update for the COVID-19 recovery strategies. And I think it's important coming into this to have all that has come before. And all that has come before is the reason that we need to recover fiscally so that we can continue to support the work. So this will be a presentation with a number of speakers. First, Paul Jenny, the Interim Executive Vice President and Chief Financial Officer, we'll present some slides about the most recent budget forecast and lost revenue. And then we will hear from Doogie Graham and Liz Engel. Doogie is the Chief Transformation Officer, Liz Engel, the Chief Strategy Officer, talking about pursuing FEMA funding and other federal relief funding to give you an update. And then there will be an opportunity to hear from the CEOs of what is happening on each campus. I have given us an hour because I think this is an important topic, and let's see how we do. So if we can go ahead and get the slides up, then Paul, Jenny, if you're ready, then we'll get started.
Sure. Thanks, Dr. Byington, Chair Lansing, and members of the Board of Regents. I'll go fairly quickly through my section. I do think, as Dr. Byington mentioned, it's important to hear the individual location updates from the CEOs. And with that, next slide, please. So when we look at the totality of the University of California, we believe the impact through the end of May is $1.54 billion, of which $1 billion is related to our medical enterprise, including the medical centers and the clinical operations within the School of Medicine in certain locations. This is a daunting number, but I do think that we are seeing some positive trends. We will certainly continue to see losses, but the growth in losses from March to April were about 120%, and then from April to May, the increase was only 30%. If you recall, the full, excuse me, the full board meeting we had in May, we had estimated that the total lost revenue across the system was $2.7 billion. But based on where we are right now, and I believe others will talk to it in a second, the increase we're seeing in census and so forth, we think that the lost revenue in corresponding expenses will be below, in aggregate, $2 billion, in particular for the medical centers, health operations. The revenue loss might be $1.3, $1.4 billion. Again, we had estimated $2.7 billion, which was a 7% impact in the fourth quarter of a fiscal year. We're thinking now, and that was 7%, $2.7 billion. We're thinking it's going to be closer to 5%, $2 billion, or slightly lower than that. Next slide, please. Again, this just kind of breaks out, again, the lost revenue, emergency medical services. They certainly included significant investments, buying as much PPE as we could and so forth. That equipment is in great need and in great use, and we will continue to invest as necessary. I should pause at the beginning of these comments, that we are still in an estimating sort of phase. We have no really understanding financially if there is a second wave and what happens in the fall. But we are right now cautiously optimistic that we are seeing return of revenue and services, crucial services to our patients across the UC system. Next slide, please. And that point of an estimation is really articulated in this slide. The top line shows what we more or less had projected, a steady state of a 3% growth, certainly higher in other medical centers than others. But across the board, about a 3% growth. And we're seeing the impact of COVID. Obviously, you see the flattening of the curve, no pun intended with the flattening of the curve with the virus, but the flattening of the revenue curve, then ramping up, or if there's a second wave, ramping further down. So we believe that we'll be somewhere in that shaded area. But again, if we are able to continue to provide the critical, essential care we have in our emergency rooms, our hospitals, tertiary quaternary care, our clinics, ambulatory surgery centers, one could potentially think that we'd be slightly higher than that blue line or that shaded area. But it's important to note that the revenue hits that we've taken are extraordinary, and will take many of our medical centers over a year to fully recover. Part of the recovery, though, is to reach out to the Federal Emergency Management Agency, FEMA. And with that, I believe I'm turning to Doogie to walk through the next set of slides.
Yuki, are you on the line?
Hi, can you hear me?
Yes, we can.
Okay, sorry, apologies. So as Paul mentioned, there were significant losses to date. For FEMA funding, we can only realize the costs and expenses associated with delivering our response to COVID. So we can't get at any of that revenue loss. But if you think of Paul's previous slides, at the moment we are ready to send in our main applications to FEMA, and we are in the ballpark range of about 150 to 160 million of COVID costs that we'll be applying to FEMA for, which is almost exactly the amount that is highlighted in the previous slide. So there may be a minor discrepancy because of the labor cost associated with the delivery. Sometimes FEMA doesn't allow that. We're working with some advisors to try and ensure that we claim every single cent we can for our FEMA funding. But at the moment, we're on track to claim a very, very large part, if not all of those COVID-associated costs to date. And that application should go in by the end of next week for all of the medical centres. I'll pass over to Liz for the other funding streams that we can try and gain.
Thank you. Next slide, please. So we wanted to talk about the key sources of federal funding for COVID. Since April 10th, the Department of Health and Human Services has distributed approximately $115 billion of the $175 billion provider relief fund that Congress appropriated. You see here on the first set of bullets on the slide, a list of the various categories of recipients. Of these funds, UC has received $290 billion, representing the UC share of the $50 billion general distribution to hospitals and healthcare providers. And then last week, we received $194 million, representing the UC share of $10 billion that were targeted to safety net providers. All in all, UC's academic health centers have collectively received approximately $484 million in federal fiscal relief. It's important to note that thus far, as Doogie highlighted, this is the only relief funding that may be used by our academic health systems to offset lost revenue versus the FEMA funding, which cannot. Next slide, please. There are also additional funding streams that our health centers might receive in the future. In terms of additional direct funding, HHS is allocating an additional $10 billion to hospitals that have high numbers of COVID positive inpatients. We actually didn't qualify for this funding last time. It's not clear that we will, but we're monitoring that closely. There's also $60 billion in the provider relief fund that HHS has not yet allocated. UC Health and federal government relations have been working with our trade associations to advocate for a better formula that targets future distributions to us. Several of our health centers, it's worth noting, have also applied for telehealth grants that are available from the FCC. These grants are a maximum of $1 million per applicant, and we hope to hear back on those soon. From the CARES Act, there's also money that flows through the state for which UC might be eligible. There's another $8.8 million in funding to California for the existing hospital preparedness program. This can be used for purposes such as surge and isolation capacity. There's a $10.5 million in grants to California via the California Hospital Association. UC received about 200,000 in the initial round and expects another modest distribution. Notably, in the most recent stimulus bill, $11 billion was allocated nationally to states and localities for testing. And this includes funding for contact tracing and to support employer testing. There hasn't been yet any guidance about when or how these funds will be released, but we'll be planning to track them. There's also a state and local relief fund, but admittedly, while we're exploring whether we might obtain some of this funding given stretched state and local budgets, it seems unlikely. The key takeaway here is that while there are huge amounts being appropriated at the federal level, our share thus far has not offset our total losses of revenue. And as you know, Congress is in the process of developing and debating a CARES Act 4, but we are not expecting any game-changing amounts of funding from that if and when the bill moves forward. In any event, our teams, our UC Health, together with government relations and finance, are turning over every stone to pursue all possible funding opportunities. And with that, I'll turn it back to Dr. Byington to talk about our recovery.
Thank you very much. If we could have the next slide, please. We have one more slide, please. We have talked a number of reasons, a number of ways that we hope to return to our normal patient revenues and ability to serve. And so I just thought to show from the system our occupancy rate. So this is a system-wide view from late April to the current day. Where we started was approximately 60% as a system over that time. And where we are today for our inpatients is right about 76%. There is variation across the system, which really reflects local conditions, and particularly in Southern California, where the number of cases of COVID have not declined. It is more of a management and operational issue to try to bring other non-essential cases back. Next slide, please. This is our ambulatory data. So we are also working very hard to make sure that our outpatient visits return to normal. And these data reflect from January until the present. And the blue color represents the number of visits that are done in person, whereas the orange or gold color represents those that are done through telehealth. And what you can see is pre-COVID, we had very few telehealth visits that were occurring across the system. And then over a very short period of time, in March, we were able to transition as a system to begin to offer large numbers of telehealth visits every day. And so you can see the number has increased over time. And what we are seeing at this point in time is that we are now bringing back some of our in-person ambulatory visits, and the telehealth numbers are declining just a little bit. Even with the combination of telehealth and in-person visits, we are not yet at the level that we were prior to COVID-19. And so this is an option, an area of intense discussion at this point at a system-wide level. How can we leverage what we have learned and what we have developed for COVID to increase our access across the system, across California, and to perhaps design new lines, new service lines for care. So you're going to be hearing a lot more about telehealth, and even as we advance our ambulatory visits in person, we do not believe that we will lose our telehealth capacity. It is our goal to preserve that and to use that in new ways. I think this is the last slide that we have. You can tell me if it's true. Yes. And so now I had asked each of our CEOs and vice chancellors at each campus to speak just a moment on their own campus to give a feel of what's happening locally, because it is unique on each location. And I'm going to recommend that we do that in alphabetical order by campus name. And so the first campus that we will hear from is UC Davis, if you're ready to just give us a few moments.
Sure, Carrie. Brad is sitting 6 feet away from me, and we'll cue him in as well. So we, again, as we mentioned during the hospital presentation, we've been very, very fortunate. We are actually, compared to our baseline from July through February of this year, which was already, we were well ahead of our expectations for volume. We have recovered fully to those elevated levels And as most people know, we like last evening, we were at 96.5% hospital census capacity. That's really more than 100%, since with double beds, we have to block a variety of them off for infectious reasons and behavioral reasons. So our hospital is totally filled. Our ambulatory volumes are about 105% of our pre-COVID levels. Our surgery is at our 105% of pre-COVID levels. Our ED remains slightly below about 5%, about 95% of pre-COVID levels. But we're actually happy about that. It was overfilled, somewhat inefficient for those reasons, and people hopefully are self-selecting out that they don't really need as much emergency care when they're not really that sick. So that's actually a positive for us. And our attendant revenues, again, we've been extremely fortunate. We were able, because of our ability to secure our supply chains and PPE for all of our staff very early on. We began that back in January, preparing for that, as well as our ability as a partner in the state testing task force to get preferential assignment of reagents. We were able to not only provide PPE, but also appropriate testing of various admissions and procedural patients in a way that allowed us to reopen much earlier than some other organizations. And as a result, will post a very strong and stable financial picture this year. We obviously include the books, but our CFO is obviously on this call and totally on top of our performance and done a great job with that. So that's kind of just the summary for EC Davis, and we just count ourselves extremely fortunate.
Thank you, Dr. Lubarsky. And I think we'll save questions for the end. And so now we'll hear from UC Irvine, please.
Thank you, Dr. Byington. This is Chad Lefteris, the CEO at UC Irvine. Thank you for allowing us to take a minute to do this. It's hard to follow Dr. Lubarsky. He has a great story there and a lot of similarities you'll hear across all of us. I'll just start with what's happening here in Orange County a little bit differently, is that we're seeing a tremendous late surge of patients. We have been averaging around 20 to 30 inpatient positive COVID patients. Really, that's been our average. And over the last 10 days, we've spiked to a high of 51, and today we're at 48. And so we're very, very closely monitoring this to see what that means, because at the same time, just like Dr. Lubarsky mentioned, we're ramping up other services, which just to give you some statistics similar to what he shared, our inpatient census is around 90% already. Our ambulatory visits, you just hit on it, we're at 118%. And 20% of that is still virtual visits. And I don't think that's ever going to go away. And in fact, I'd submit to you all that let's stop calling it that. We don't talk about telebanking anymore. It's just the way we bank. This is going to be just the way we visit in many ways with our patients. Our surgery volume is at around 90% of what it was pre-COVID. And our ED visit volume, much like Dr. Lubarsky mentioned, is here at Irvine is also about 90% of where we were. But that may be a good thing, because we were overcrowded so much in our emergency department leading up to COVID hitting us. We've taken 7 patients from the border counties and staying very closely knitted together with our colleagues at San Diego who are doing so much there. And I think that's the beauty of the strength of the UC system, if you will, that we can move patients where they're in need. So we're keeping a close eye on that. Our ratio, when we do have those inpatients now at 48 today, our ratio of the amount that's in ICU and the amount requiring ventilation has stayed remarkably constant from where we had 20 patients and now up to 50 almost. So we're tracking that very closely, and also tracking the amount of coworkers who may be out due to COVID positive as well, and supporting them in lots of different ways. We continue to really be the source of truth for Orange County, and partnering with the county healthcare agency on contact tracing, and our infection disease prevention folks are very involved there. And also our laboratory team continues to provide testing not only for us, for our main campus, but for many other healthcare providers in the county, as well as first responders. And I love it how competitors are coming together to send messaging, but also coming here for their testing needs, which is pretty nice. We've also had a new partnership with now 3 different large employers that are asking us for their expertise, for our expertise to help them return to work. and bring their coworkers back into their offices or whatever their workspaces may be. So we're serving in that capacity as well. And then I'll just leave you with, we continue to advance the ball on other things while this is happening, starting up several new programs that are significant and the only types of those programs here in Orange County. We've done this while we've been running the marathon here of COVID-19, and we're very closely monitoring our PPE. We're very nervous as as other volumes return, and now our inpatient volume is spiking. We're just keeping a very close eye hourly on PPE. So I'll stop there, and thank you again for the opportunity.
Thank you, Chad. And we'll go to University of California, Los Angeles, UCLA, please.
Well, thank you. Good afternoon, everyone. Johnny Schizo, President and CEO of the UCLA Hospital and Clinic System. Good news to report from the UCLA health system as well, similar to my colleagues. Prior to COVID-19, as many of you know, our 4 hospitals ran at about 95 to 105% occupancy. I'm really pleased to say today that as I'm here at the Ronald Reagan campus, we are 99% occupied with 28 patients awaiting admission in the ED. Our Resnick Neuropsychiatric Hospital is at 95% occupancy. Our UCLA Santa Monica Hospital is at 87% occupancy, and our Mattel Children's Hospital, also the same as Reagan, at 99%. Our emergency department visits are back up to about 75% of the pre-COVID levels. Our operating room, ambulatory surgery suites, and interventional procedures are at 85 to 90% of pre-COVID. In our large clinic network of 180 clinics throughout Los Angeles, pre-COVID, we averaged about 50,000 clinic visits a week. We've been steadily increasing. We're up to about 42,000 a week now. In the next 2 weeks, we expect to be at 100%. About 75% of those visits are now back in person, with another 25% video or telephone. I do want to mention that during the entire pandemic, the one area, because we have 200 oncology chairs in the community, our oncology patients were still able to safely and effectively come in to those clinics and get their treatments. It was much better than bringing them into a hospital environment. And so our oncology visits are actually up 5% from pre-COVID. In regards to testing, we continue to actively test. We can perform over 1,300 PCR tests a day and 300 serology tests. To date, we've tested 30,000 patients. About 1,200 were positive, and we've hospitalized a total of 275 patients between our 2 campuses. Our peak census of inpatient COVID was around 60 several weeks ago. We're now running 20 to 25 per day. In relation to supplies, we have been able to secure great amounts of supplies that will help us through a surge. We've had a remarkable response from the philanthropic community and also other community partners. We're also sharing some of that PPE with our training partners at Harbor UCLA, at UCLA at Olive View, and also the Venice Family Clinic, which is our federally qualified health center where all UCLA employees work, and that group provides services to about 40,000 underserved. As Chad mentioned as well, we're also supporting a lot of community businesses on their restart. Our UCLA athletics, the professional sports, the entertainment industry, and some other key businesses in the community have asked for our infectious disease expertise to help guide them. I think that's all I have to say.
Thank you very much. And now we'll hear from San Diego.
Great, thank you, Carrie. I look around at my colleagues and I apologize, I'm not quite as dressed up as they are. I'm actually sitting in Jacobs Medical Center as an inpatient. I'm on about this 5th floor here, hopefully about to get discharged. I don't have COVID. I did the test on the way in, and I've decided that we definitely need to move past the nasal pharyngeal swabs to saliva and nasal swabs, and I know our teams are working hard at doing that. You know, on the ground as an inpatient, just a couple of personal notes. One is it's really quite amazing what our teams are doing, but I can't emphasize enough how difficult this has been on our patients to not have visitors. The visitor policies throughout the state are guided by the counties, and so there's very limited visitation to patients, and our teams have been incredibly creative in coming up with FaceTime and iPads and all sorts of ways to connect the families with the patients and the care teams. And so just a shout out to all of our teams for being really creative and trying to keep everybody connected with their families and their loved ones. Secondly is that our workers, they're essential workers, but the nurse that's taking care of me today, for instance, has 3 kids that are 6 and under. Her husband works, she works. They need to get those kids in school, they can't. And it's a really, really big burden. So just to call out and remember our teams as they try to manage through those very difficult situations. In San Diego, our journey began 133 days ago with the first flights from Wuhan, where we took care of the first patients that came from Myanmar. That we learned a lot in those early days. And I think as I look across the region at our other health systems, we've been ahead of the game pretty much the rest of the way. And that has to do, I think, in part to the fact that we learned a lot in those early days. We got PPE in place, we started testing, we really got the infrastructure, the command centers, et cetera, going early. And so it allowed us to, I think, manage through this and fare well with respect to the region. Just in terms of the numbers, we're back to 93% of our inpatient census. We're at 101% in our peri-op volume compared to pre-COVID. Our ambulatory visits are at 83% of pre-COVID visits. A certain portion of those, again, are now telehealth. The telehealth volume ran almost 50% of visits for a while, and now the face-to-face visits are beginning to pick back up, and the televisits are dropping, but we, as others have said, don't expect those to drop much below 30%. 2 stories I would want to share with you that I think one fits quite nicely in what we talked about earlier, and that is the work that we've been doing across the border. And in Imperial County, if you've watched the maps of where the patients are coming from, obviously there's been an incredible crisis in Imperial County. A lot of US citizens coming across from Mexicali and Tijuana. Both regions have been completely inundated. It's been really a humanitarian crisis. And I think the challenge that we've had, similar and yet different than New York, is we had all the politics around the government and the borders to navigate while trying to support efforts. So we had care teams that started over 2 months ago, heading down to Tijuana with PPE and developing critical care protocols. What happened in Tijuana is that all of the older physicians were either called off or got sick. And so basically it left those hospitals being managed by barely graduating medical students managing really complex patients on ventilators. And so our teams were able to get down and create protocols. They round on them every single day. Our team goes down and rounds on those patients and supports the critical care efforts there. Mexicali is another big firestorm, and we sent a team down there last Thursday. And because they're a little bit further away, they're going to be a little bit harder to provide that kind of hands-on support that we're doing in Tijuana right now. But they are able to do telehealth and to build out protocols and support them. When we first saw the patients coming from Wuhan, we got on the phone. We manage El Centro Regional Medical Center, which is one of the 2 hospitals in Imperial County. And as you know, that's been really inundated. We kind of anticipated that. And so I called the CEO, who is actually, you may not know this, but the CEO is a UCSD employee, as is the CMO. And we said, we have got to get critical care out there now because this is going to become a big issue. We supplied telecritical care services to them so that they were able to keep patients. So if you can imagine pre-COVID at El Centro Regional Medical Center, they could maybe keep 6 patients a day in critical care. Everything else they transferred out of the region. And today they have over 40 patients there. And that's just because of the supply and the support that we've been able to provide there. So I'm really proud of the teams for being able to do that. So as we look forward, we're seeing a stabilization, much like the plateau that Carrie laid out earlier. We're not seeing any real declines in our care, and a lot of it has to do with, again, the patients coming from east and south. And so we continue to expect that to be an issue for us.
Thank you so much, Patty. And last but not least, San Francisco.
Thank you. And Patty, we wish you all the best. And we think maybe you have taken the effort to increase census to too high a level. So I don't think we should all be admitting ourselves. Like everyone else, our story started back in March with actually in February with our first patient the week before Super Bowl Sunday. We, on pretty much every metric, we're down 30 to 50%, whether it's admissions or ED visits or operating room cases or so forth. And like everyone else, mostly we're back. We're not quite as far back as some others, but in some areas like our surgical volume, we're actually higher today than we were in January and February. Our ambulatory visits are right back to where they were, although a big portion of those visits are now telehealth. So it's we think we can actually increase our ambulatory capacity. We're about 88% on inpatient activity. And the one area that has been mentioned is just how low emergency department visits went. In our case, down to about 50% of where they were before, and we're still around there. So we're not quite sure where all the emergency patients have gone. We just want to make sure that they're getting the care that they need. I think just a couple of comments. One is that we shouldn't underestimate how much this down period has hurt our faculty, who rely on, in many cases, clinical income to support their salaries. Departments, a lot of our programs rely on clinical income, and we have taken a serious hit. So I think this is a real challenge for many individuals at a very human level. It's also been a very difficult time for staff as they have had children at home, spouses laid off, trying to manage in a very difficult time period here. And those issues still continue and something that we want to put a lot of energy to. And finally, I mentioned that I think for us, one of the challenges of coming all the way back is how do we think about social distancing? For those of you who've been in our Moffitt Long hospitals, we had a problem with elevators before. Took forever to get up to the floors you wanted to get into, and we packed every elevator like a can of sardines. And now we're trying to socially distance, and we're trying to figure out how do we actually operate in that kind of an environment where we simply can't put so many people in such small spaces. Similar situation in our ambulatory care areas. But we're working on it, and I'll just end by saying that we are encouraged that the demand is still out there. The demand for our kind of care is still there. We're getting more than 35 transfers a day from other hospitals. So I think long-term, it's a good story, but with a lot of near-term challenges. Back to you, Dr. Byington.
Thank you so much, Mark. And I think Regents and others, you have heard each of our.
Gary, Dawn is prepared to present as well.
Oh, okay, great. Okay.
Sorry, Gary. Sorry, Dr. Yeah, no, it'll be quick because as you all know, we're a bit smaller at UC Riverside Health, and so we don't have a hospital of our own. But we've been experiencing very much the same in terms of our ambulatory clinical experience. And so back early in March, we pivoted pretty quickly to our televisits and phone call visits in our ambulatory sites. Fortunately, we're already prepared to be moving in that direction in our psychiatry department. So we were in 72 hours pretty much able to reschedule most of our visits, if not all of our visits, to a televisit model. Today, we're back to almost 80% of our total ambulatory volume, which includes televisit. And you know, like at UC Irvine, I don't know how much of that is ever going to go back to face-to-face visit, and it is the new paradigm. So we're planning on that going forward, is how do we integrate televisits into our model of care permanently going forward. We also provided, especially in psychiatry, a lot of our providers provided care from home in order to protect them during that period of time as well. And some of that is still ongoing, although a lot of our clinicians have moved back into the clinic. We do provide hospitalists for several of our community hospitals, and our adult hospitals programs have been working double duty during this period of time. Our pediatric hospitals have been slower because some of those hospitals have been closing some of their units, or at least downsizing some of their pediatric units during this period of time. With regards to PPE and supplies, we've had sufficient supplies, thank goodness, and we've had philanthropic support as well. And we have also been sharing our PPE and supplies with members of our campus, the UC Police Department, and our campus research teams as well. And then finally, back in March, UCR Health stood up a employee and faculty resource, a hotline to answer employees' questions, and that's a building and is more robust than it was back then. And in fact, UCR Health has added under Dean Dee's guidance with the School of Medicine support, 3 task forces to help our campus reopen. One is a public health task force. One is employee health assistance, is where UCR Health provides the most assistance in this regard, and a student health task force as well. So together, we're working using the School of Medicine as mortar between the tiles to hold us all together to help our campus recover, because we don't have employee health and occupational health at UCR. So UCR Health is providing that function currently, some of that function currently. That's all I have.
Well, thank you so much, and thanks to everyone. I think the regions have heard some similar themes across the campuses, testing, data, and PPE. I would like to shout out to our laboratories today. We have passed 100,000 tests done across the system this week for our patients alone, and we've probably done an equal number for all of our community partners. Throughout this pandemic, data has been critical, and so I'd like to recognize Dr. Atul Butte, who has helped us create dashboards and tools to track everything from our ventilators and ECMO tests, PPE, personnel, and having a real emphasis on system-wide data and standard data sets that we can use and share is going to be important moving forward. And then just a final mention on PPE. Although we appear to have sufficient PPE today, it is a constant challenge and concern, especially moving into the fall and winter, when we will also see influenza season. I have had discussions with the president on this. She has challenged us to have 90 days of PPE on hand. I think that is a good aspiration for us to be working towards, and it's something that we're working with all of the campuses through the Health Coordinating Committee, making sure that we have the PPE that we need, and is going to be vital. So I'm very proud of the work and the balancing that's gone on all of the campuses and the medical centers. This will be our life moving forward for the next months to years, balancing COVID and being chronically prepared for surge. And that will have a set of ongoing costs and new costs, and as we try to manage through all of those. So we're very happy to answer any questions that you might have. Regent Lansing.
Great. It was a great presentation, and it was wonderful to hear from the CEOs directly. First of all, I have just really a couple of questions. At Irvine, which was the one that is preparing, for more cases. I only know what I read in the paper, so please, this is certainly not in any way necessarily accurate. But I understand that as compared to, for example, LA County, where you have to wear a mask, and it's actually almost the law. Orange County has said no to masks. They said that they didn't have to wear them. And I wonder if you think that accounts for your surge.
Hi, Regent Lansing, this is Chad. I think that's a great point. You're hitting right on one of many causal factors. There's been a lot of news around the county healthcare agency changing their position on this. And I won't go into that, but I can tell you that we're reminding our coworkers, whether you're here at work or when you go home, that the benefits of wearing face coverings is still very important. So I think we're seeing a lot of anecdotal statements around that same comment, around beaches opening on Memorial Day and then a spike to follow a few weeks later. So I think it's all that. I'll defer to the scientific experts that are on this call, but that's my opinion of what we're seeing around us and what we're hearing around us here in Orange County.
Yeah, I think that at this point, in some ways, we had predicted this because the coasts, which are more affluent, had the early cases because of international travel. More inland are the less well-to-do communities who had to continue going to work, who live in high-density environments. And we expected this slow, steady rise from those communities. And that's where we're seeing the increase now. The lack of masks may bring it back to the coast.
Thank you. That's very informative. And also UCLA, just wanted to ask you, said 25 cases per day. You're not talking about 25 additional cases per day. You're saying that you're averaging 25 ICU cases per day. Is that correct?
Yeah, an average daily census of a 25. That includes only about a third of them are in the ICU.
Okay, great. And Patty, I hope you feel better. Your experience as a patient. I hear you're going to get released today, you hope, but your experience as a patient brings it all home to us. All right, well, we only have 2 questions. So I'm going to go to Richard Lee, Regent Lee, and then to Steve Lipstein, and who I am so grateful for being with us from day one. And those are the only 2 questions I have, and then we'll move on to the next item, which we will have time to do.
Yeah, and mine is very short. Thank you, Regent Lansing.
Doesn't have to be short. We're doing okay.
Okay,
Everyone can
I'll make it really long then.
No, don't.
No,
I don't want anyone to think I'm censoring them.
I first want to shout out to my friend Patty Mason and wish her best and hope to see you on the streets of our neighborhood soon. But my question is, and this one does not have to be answered, in full detail today. It's a question I have about the increase in telehealth and how that affects our UC hospital over time. Are the reimbursements rates going to make this a better venture for us to be doing this? Is this just a necessity? It's certainly going to increase access and more people able to go, but I'm just curious the economics of telehealth.
So this is Janice. I'll just start and say we are able to get billed for those visits. We get billed at more of the intermediate level, a level 3. So it isn't the same as when someone is coming in person. But the good news on that is it definitely allows us to expand our capacity in the same amount of physical space by patients who are willing to be seen by a video visit and don't need an in-person exam.
In the backyard. And it produces a very low no-show rate. People show up. And in a city like LA, where you can't drive anywhere normally, it's a great convenience for the patients. It may result in fewer referrals. We're just starting to look at that now. And it's more difficult for elderly patients to manage and figure out.
For us at UCSF, our clinics are hospital-based clinics, so we get paid the same for a telehealth visit as an in-person visit for our commercial insured patients, but for Medi-Cal and for Medicare, we get paid considerably less. So that is an economic issue. Now, theoretically, there's a cost savings. We don't have a an MA or medical assistant checking you in, and we're not using office space or exam room space. But it is a consideration that we're trying to sort through right now. In general, though, our hope is we can get our in-person visits back to where they were beforehand and use the telehealth visits as additive capacity, which we needed before. So hopefully the net is a plus.
Yeah, Mark, you just hit it perfectly. I think that's the way we're approaching it here at Irvine, and also looking at our future growth plans for additional sites and exam rooms and all that. We start to shrink that a little bit because we can shift more volume, just like you described. So I think there's some positives on both sides of that equation.
This is Don. I'll also add that I think this will be hard to take away from patients in the long term. And I think, you know, our CMS administrator, Seema Varma, came public earlier this week saying that CMS is looking to make this permanent. Whether that actually happens, I don't know, making coverage permanent, but it'll be hard for beneficiaries to give it up as well. So maybe here to stay.
I said, I think you're right. I think like Zoom calls, this is the new normal. Unless someone else has something to add to that. Okay, Steve, it's all yours.
Sherry, thank you. Two things I wanted to, a question and a comment. Patty, the remark Patty made about visitation in the hospital really strikes close to home, because in the middle of this COVID outbreak, my wife Susan needed severe abdominal pain, and that experience was just dropping her off at the emergency room and having a nurse take her in, and nobody could go in with her. 2 hours later, she had emergency abdominal surgery and stayed in the hospital for 8 days. And she went through that whole experience by herself, where you could FaceTime and you could talk, but it certainly isn't the same. And so it just renewed my appreciation for how important families are in the healing process. And so to the extent that the hospital executives and your teams are being very creative with regard to visitation, I think that was an important point that Patty made. My question, and I guess it's a question for Dr. Byington, is as I listened to the presentations, and Jerry said it early, I mean, the heroic efforts of the leadership team at the medical centers has been remarkable. It would appear from the slides that there's been $1 billion in lost revenue with so $500 million in recovery through various federal sources. The remaining $500 million is a lot of money for the University of California. And so I guess my question is, if there are not other sources coming from Washington or from Sacramento, will the university medical centers embark upon some kind of a cost reduction or cost recovery agenda in order to generate those resources for the good of the university?
Steve, thank you for that question. And it is something that we are discussing very regularly at our CEO meetings. And we need to look for ways to reduce our costs, become more efficient, and look potentially for new sources of revenue as well. And then I look at this, this acute loss that we've faced and hope to think about a strategy where we can recover over time, that it's not going to be something that we can recover in 1 year, but working together to recover over time. But it is a stressor to the entire system, on top of many other stressors that, that already exist. So something that we are working towards.
Thank you, Steve, and I'm glad your wife is feeling better. Regent Park for the final word, and then Dr. Byington, you can go on to the next item, which is H7. So Regent Park for the final word, and then back to you, Dr. Byington. And again, in the presentation, just because of time, we have read everything. Okay, Regent Park.
Thanks, Sherry. So I guess I'll direct this to Paul, since I think, Paul, this is part of your slides, but you may want to call on somebody else for further explication of the answer. And, you know, we are in a much better place than I had feared we would be at this point in time. So all of that is good news, although I think there's still so much to worry about, right? Especially as states and communities enter into, you know, the later phases of reopening. You know, we're in some ways probably wondering, are we going to be just in the same place that we were before? So time will tell, I guess, in terms of the level of infection and hospitalization. But so the question that I have is on your slide deck, and it is the one opposite the little shaded area with the graph. And it's really about stabilizing revenue and liquidity and the risk to revenue. So my specific question really has to do with the risk to revenue, the change in the payer mix due to unemployment, and then on the flip side, the expanded COBRA coverage for patients. And I can't remember if you've modeled this or taken a shot at modeling this based on the prior recession, but could you or somebody else speak about kind of the level of risk, you know, because the unemployment is a lot more severe in a lot of ways than the prior recession. So can you talk about the level of risk? And, you know, people probably have been hanging on to their insurance in some way, but as unemployment continues, what can we expect?
That's a good question, and I would I can give some brief overview, but then turn to one of the CEOs or if there's a CFO from one of the medical centers. And you know, at UCSF, we're certainly modeling a degradation in the payer mix. What happens if commercial drops 2 or 3 percentage points, and it is significant, and that has been modeled. We haven't, at least that I'm aware of, seen much change in payer mix yet, but we're early days into this. And as people run out of COBRA or other effective means to cover their insurance, that is a huge risk for us. But it also varies by the medical centers. The unemployment rates might be very different in the Bay Area than in San Diego, LA, or Davis or Southern California. So I think it would be to give an illustration to your question, I would turn to one of the 5 medical centers to see if someone could answer specificity on payer mix and COBRA and their own experiences.
Paul, in San Diego, this is Patty. Couple of things. You know, we are beginning to see a degradation and movement to Medi-Cal. And so as we think about our capital projects going forward, I mean, we've already stopped a number of our projects or delayed our projects for a project that we'll bring forward later, the outpatient pavilion in Hillcrest. You know, we're rerunning all of those business models, anticipating that there's going to be a much higher Medi-Cal rate than what we have today. And so I think it's going to be very material.
So this is,
Oh, go ahead, Paul. We're going to say.
this is Paul Staten, CFO at UCLA. So we're seeing projections of LA County that the Medicaid enrollment is going to increase by about 14%. This is the state's projections. So next year's budget, we're modeling about a 10% shift out of commercial into Medicaid. Just for us, that's worth about $70 million of differential revenue. So we'll have $70 million of less revenue next year just for that shift. So it's a pretty substantial hit to the bottom line.
Yeah, and I was going to say the projections in Los Angeles, which is already the largest Medicaid expansion county in the country, another 600,000 are expected to move from commercial into Medicaid. So for us, it just means we have to continue to work on being more cost effective so that we can serve the population.
And I would add to,
Go ahead, Mark, please.
I'll go quick. Just adding to Steve Lipstein's question about where's the money coming from. There's so much that you can cover from your reserves, but I think what Regent Park is raising is the big question. For us, we so far have had no degradation in sponsor mix. Actually, May was a little bit of an improvement. But as Paul mentioned, we're looking at a 5% degradation over the course of this next year. We could make it worse, but we're not, it's really a shot in the dark. But even that 5% has really profound impacts on our budget.
I was going to say the same, Mark. I think we're having a 5% estimate in our new budget. We're starting to see, as Patty mentioned, some degradation here in Irvine already, but small amount, but it's going in the wrong direction.
And I can add too back to, I'm sorry, go ahead.
I would just add to that, just at UCLA, if you take into account the federal support, there's still $100 million missing out of the budget, and that's the margin. That's what we use to cover the academic mission. The surgeons who were idle for 2 months, they're in a serious situation, as Mark mentioned in UCSF. So yeah, it's good to see the recovery and the numbers coming up and the percentages, but there's a big hole that we're going to have to account for over time.
That was where I wanted to go as well, John. And same in San Diego, $100 million hole to make up. And tying back to Regent Park's question a little bit. I mean, we are needing to make changes relative to our labor profile, as well as our non-labor expenses. And we're looking at just to give you a full view of it. We can look at not filling positions, which we've been doing very extensively, to not using contract labor, which we've been doing very extensively, to working people at their appointment times rather than working them above their appointment times, to temporary reductions in time, et cetera. So, I mean, I wouldn't want anyone surprised to hear that we are managing those levers pretty hard, and we'll continue to do so.
And sorry to come back in, but Dr. Byington referenced something very important in her remarks, and I just want to put a double underline under it. University of California is a major employer, and it has an enormous number of people who have commercial insurance. We do not, in general, provide much or any incentive for those employees to choose a health plan that features UC medical centers, the best hospitals in the state, for their health insurance. And so one of the things that we can do to help preserve jobs inside the University of California is to do the best job we can to redirect those premium dollars back to health plans that encourage employees and their families to get their care at UC Med Centers. And I hope that's a place that will make some progress, but I thank Dr. Byington for her leadership on that.
If I may, Mark, thank you for bringing that up. As you know, you have 100% of the vice chancellors and CEOs feel exactly that way, and that we should have the opportunity to take care of our family of employees. And frankly, that those dollars are better spent inside of our organization supporting academics and research and training than they are flowing out of our organization. So thank you.
Thank you.
Yeah, that's a really interesting point to bring home about us pulling levers to preserve our own jobs in that sort of redirection. So that's a great, I think, point to make. So just in the long term, even though a lot of the patient services have come back, sounds like there's still a lot of concern over the next few years about other pressures. Was that 14% increase or 14% expected Medi-Cal growth based on, was it tied to unemployment numbers per se? I'm just kind of curious in terms of that nexus, how tightly a correlation there is. I assume, there's a certain level of uncompensated care too that is probably going to grow. Is that?
Yes, I mean, certainly in LA, it's been tracking with the unemployment. And, with the Affordable Care Act, we do a really good job of getting everyone on Medicaid, right, or Medi-Cal. So we really work to get them signed up. So uncompensated continues to go down as we get more people in the program.
Right, but not everybody will be eligible.
Not everyone qualifies, that's
everyone,
right.
no.
And we have a large percentage of patients, even in our Venice Family Clinic, that are pure charity care.
Okay. Okay, well, thank you everybody for the responses. That's really helpful.
Thank you, Regent Park. And these are some of the topics that we're going to be developing at our July strategic planning session. And we'd like to bring some of the plans to the August health services and discuss them more fully, because we do need to use all the levers that we have to get through this, for the good of the entire system. Okay, Regent Lansing.
Yes, Dr. Byington, thank you. And Dr. Lark, thank you for those incredible questions. So unless someone objects, I'm just mindful of all the emails I'm getting. I have to get off. I'm sorry I can't be there, blah, blah, blah. And I understand that we were scheduled to finish at 3:15. It's now 2:46. The next item, which is on our responsibility for serving on the board, is scheduled to be an hour. What I would like to suggest, unless Dr. Byington, you feel this is particularly time sensitive, what I would like to suggest is that everybody read it and we push it over for the next month's meeting. What are your feelings about that?
I agree, Regent Lansing. We had a robust discussion about this topic at our Quality and Population Health meeting immediately prior to this. And there were some recommendations from that committee that we would like to incorporate. So it would probably be best to bring it back next time.
Okay, so that's what we'll do. And then we're going to end on time. What I'd like to suggest now is that we take a maximum of 8 minutes, okay? Just now we all sign off, we all sign in, and then we go into closed session. But I know that Kumkun, you wanted to say something before we went into closed session.
Thank you, Sherry. Thank you, Regent Lansing, Chair Lansing. Yes, I wanted on behalf of the Academic Senate to thank Dr. Stephen Hetz for his sterling service to the Regents Health Services Committee. He's ensured that Senate stays informed on what's happening. His background as a very eminent medical person and scholar has helped Senate enormously, as I hope it has helped the Health Services Committee. I really can't thank Steve enough on behalf of Senate for his service to the Senate. Next time, it'll be Dr. Andrew Bindman, who has been recommended by Senate for 2 years to serve on Health Services Committee. Andy Bindman is Professor of Medicine and Epidemiology and a core faculty member at UCSF. He's a primary care physician. He has federal and state health policy experience. He's been working for 30 years in these areas. He was appointed as director of the Agency for Healthcare Research and Quality within the US Department of Health and Human Services in 2016. And he served in that role until the end of the Obama administration. And he is the founding director of the California Medicaid Research Institute. And in 2018, he authored a report for the California Assembly Select Committee on Healthcare on proposals to expand coverage and access in California. He is currently leading a University of California-based team in support of the work of the Healthy California for All Commission. So whilst Steve's shoes are very, very big to follow, perhaps Andy will be able to step into them and maybe rise to your level, Steve, in a little while. Thank you very much for allowing me to have those words. Thank you,
Thank
Steve.
you. Thank you, Kumkum.
Kumkum, I would just say to the whole committee again, it's been an honor and a pleasure getting to work with you all. And you will definitely be trading up with Andy. He's a real brilliant guy. I'm just a catheter jockey, but it's been a wonderful experience. And I hope I've helped more than I've hindered.
Well, Steve, on behalf of all of us, your service has been incredible. And we are looking forward to keeping in touch since you're part of our UC family and calling on you when needed. And as I said, also to the other Steve Lipston, you've been there from the very, very beginning. You were always a person that I went to with a million questions. And as I said, I twisted your arm for this extra year. And I'm very, very, very grateful for your wisdom, for your work on the strategic plan, for all the many, many, many ways that you've helped us. And it's going to be hard not to see your face at all these meetings. So thank you again. And with that, if everybody can now, thank you. And now we're going to go into closed session. So a round of applause we can have for the two Steves, and we'll go into closed session. Okay, thank you, everybody.
Thank you. Thank you very much.